Please maintain silence. We are live now.
Good morning, everyone, and welcome to the second day of our seminar on palliative care. I am Harsha Tripathi, accompanied by Miss Priyanka. We both are students of MSc Nursing. It's great to see you all again, and we are excited to continue our discussion on palliative care.
Dear all, as we begin seminar, let us take a moment to reflect on the importance of spirituality in palliative care. It is a wonderful way to begin us together and set a positive tone for our seminar. Please join us in a prayer song led by Miss P.
Yesterday, we had a great lineup of speakers Miss Divya, Miss Harshita, Miss Priyanka, Miss Shubham, and Miss Piyush, who shared their knowledge on various aspects of palliative care. We learned about
Explore, explore end of life care, and our third speaker, Miss Shivani, will discuss the topic of drug in palliative care. And our final speaker, Miss Supriya, will delve into the topic of service delivery framework.
Please join us in welcoming our first speaker of today's session, Miss Archana, who will discuss the topic management of wound ostomies and emergencies in palliative care. Everyone give a big round of applause for Archana.
Good morning, respected principal sir, vice principal ma'am, and myself Archana. I am going to present management of the wound care, ostomy care, and objective. At the end of seminar, the audience will be able to gain depth knowledge about management of wound, stomas, and emergencies in palliative care, patient and develop positive attitude towards the topic and able to implement the practice in clinical setting. Uh, my specific objectives: first is the define of malignant wound. Second one is the discuss the problem of malignant wound. Third one is the explain the assessment of wound. Fourth one, elaborate the management of wound. Fifth one, enumerate the management of malignant one. Then about the stoma care. Seventh one, discuss the management of emergency in palliative care. First, what is the wound? First, we know about what is the wound. After that, we have to go malignant wound. Wound is the cut or injury of our body. It is a type of lesions which have which have to do accidental or any fighting. Our body is cut and lesions and cut our body or injury or breakdown of the any skin layer our. After that, we have to discuss about malignant wound. Malignant wound is the cancerous. You you know what is the malignant? Malignant means क्या होता है कि जो कैंसरस फॉर्म में जो हमारी सेल्स होती हैं वो टिश्यू होती है वो डेथ हो जाती है, ठीक है। उसके बाद जो वुंड कॉज होता है उसको बोलते हैं मैलिग्नेंट वुंड। Malignant wound occur when cancerous cells invade the epithelium infiltrate the supporting blood and lymph vessels and penetrate the epidermis. It means कि जो हमारी epidermis layer है वो क्या हो रही है, invasion of the layers of our epidermis or dermis layer. Next one is the fungating lesions are fungating lesions are fast growing and typically resemble a cauliflower or fungus shaped structure. It means क्या होता है कि जो फंगेटिंग लेजन्स होती है, इट मीन्स कि जो हमारी लेजन्स है वो बहुत ज्यादा फास्ट फास्ट ग्रो कर रही हैं। ऐसा नहीं है कि जैसे कि फंगस लाइक ग्रो करना उसको बोलते हैं फंगेटिंग लेशंस। जैसे कि आप कोई इंस्ट्रूमेंट या फिर कुछ खाने का सामान रखते हैं, उसमें क्या होता है कि एक दिन रखे, 2 दिन रखे, तीसरे दिन क्या होता है ओपन कर देते हैं उसको, तो उसपे क्या होता है फंगस लग जाते हैं, उसको बोलते हैं फंगेटिंग लेशंस। कि ये बहुत फास्ट ग्रो होता है, हमारा अगर कोई चोट लगी है उस पर बहुत फास्ट फास्ट ग्रो हो रहा है और लाइक फंगस। जैसे कि मैंने बताया कि वुंड इज एन इंजरी टू पार्ट ऑफ योर बॉडी, स्पेशली अ कट ऑफन वन रिसीव्ड इन फाइट। नेक्स्ट इज द माल अडोर वुंड्स। माल अडोर वुंड्स मींस क्या होता है कि जो हमारा वुंड है उसमें स्मेल, बैड स्मेल आना, जैसे कि अनप्लीजेंट स्मेल हम नहीं चाहते हैं फिर भी वो स्मेल ऑकर हो रही है, उसको बोलते हैं माल अडोर वुंड्स। इट रिजल्ट्स फ्रॉम बैक्टीरिया दैट रिसाइड इन नेक्रोटिक वुंड टिश्यू। They are usually polymicrobic, containing both aerobic और anaerobic बैक्टीरिया। इट मीन्स क्या होता है जो मालएडोर है, मालएडोर वुंड्स होता है जिसमें कि पॉलीमाइक्रोबिक बैक्टीरिया का ग्रोथ होता है। पॉलीमाइक्रोबिक मीन्स क्या होता है कि मोर देन वन बैक्टीरिया और माइक्रोऑर्गेनिज्म इंक्लूड होते हैं इसमें। अगर कोई वुंड हो रहा है, कोई लेजन्स आपके बॉडी में हो रहा है या फिर है पहले से ही, तो उसमें क्या है कि पॉलीमाइक्रोबिक बैक्टीरिया है जिसको बोल सकते हैं हम, जिसमें कि एक ही माइक्रो ऑर्गेनिज्म अफेक्ट नहीं करता है, उसमें बहुत सारे माइक्रो ऑर्गेनिज्म क्या करते हैं, अफेक्ट करते हैं। नेक्स्ट वन इज द एरोबिक एंड एनाएरोबिक बैक्टीरिया। एरोबिक मीन्स क्या होता है, जो बैक्टीरिया एरोबिक मीन्स क्या होता है कि जो बैक्टीरिया ग्रो करती है विथ ऑक्सीजन, एंड एनारोबिक मीन्स क्या होता है कि विदाउट ऑक्सीजन जो बैक्टीरिया ग्रो करती है हमारे बॉडी में, उसको बोलते हैं एनारोबिक बैक्टीरिया। For the most part is the anaerobic bacteria that पिट्रेसिन एंड कैडावरिन, ये बैक्टीरिया के नाम है विच रिजल्ट इन फॉल ऑर्डर्स, ये बैक्टीरिया के नाम है, ठीक है। एंड सम एरोबिक बैक्टीरिया सच एज लाइक एक्सीरिया कोलाई, ये डेवलप करते हैं हमारी बॉडी में, जो कि प्रेजेंट होता है डाइजेस्टिव सिस्टम में। Problems of malignant wound. There is a two problems. First is the physical problem. Second one is the psychosocial problems. Physical problem में आता है आपका माल एडोर, सेकेंड है एक्सोडेट, नेक्स्ट वन है ब्लीडिंग, नेक्स्ट वन है पेन, नेक्स्ट इज द प्रूराइटस। एक्साडेट मीन्स क्या होता है? एक्साडेट मीन्स होता है कि जो हमारी बैक्टीरिया सॉरी जो हमारा लेसेंस है उसमें येलो लाइक या फिर ब्लड, जो हमारी येलो लाइक ब्लड और वाटर उसमें जिसको बोल सकते हैं कि सिक्रीशन ऑफ द वाटर, जो हमारे वुंड है उसमें क्या होता है, सिक्रीशन ऑफ द वाटर, सिक्रीशन ऑफ द ब्लड, जिसको बोलते हैं एक्सार्ट। नेक्स्ट ब्लीडिंग। प्रूराइटिस मीन्स क्या होता है कि इचिंग हो, जैसे कि जो हमारी बॉडी है उस पर अगर हम लेजन्स कुछ भी हो रहा है, कोई भी स्कार्स हो रहा है, कोई भी वुंड है, उसके आसपास क्या होता है, इचिंग होता है, उसको बोलते हैं प्रूराइटिस। नेक्स्ट है इन्फेक्शन, नेक्स्ट है नॉजिया एंड एनोरेक्सिया। साइकोलॉजिकल में क्या प्रॉब्लम ऑकर हो रही है? बॉडी इमेज अल्टरेशन। अगर आपको कोई प्रॉब्लम है, कुछ भी हैपन हुआ है, जैसे कट लग गया, कोई स्कार्स है, तो उसमें क्या होता है कि आपको प्रॉब्लम होती है, जैसे कि आप कहीं अच्छे से सुटेबल नहीं हो पाते हो, अपने दिमाग में रहता है कि हम एबल नहीं है किसी से बातचीत करने के लिए, या फिर अपने आप को आपके माइंड में सेट होता है कि वी आर नॉट गुड, आप किसी के सामने नहीं जा सकते हैं। नेक्स्ट है डिप्रेशन, गिल्ट। अगर आपको कुछ प्रॉब्लम हो रही है तो ऑब्वियसली है कि डिप्रेशन कॉज होगा एंड खुद को गिल्ट फील होता है कि ये कैसे हो गया। नेक्स्ट है एम्बैरेसमेंट एंड शेम। नेक्स्ट है सोशल आइसोलेशन एंड डिलाइट। नेक्स्ट है प्रॉब्लम विथ सेक्सुअलिटी। नेक्स्ट है फियर। नेक्स्ट है असेसमेंट ऑफ वुंड। Assessing a chronic wound involve a comprehensive evaluation of the wound, the surrounding skin to determine its size, location। अगर हम देखा जाए असेसमेंट में तो फिजिकल होता है, हिस्ट्री कलेक्शन है, फिजिकल एग्जामिनेशन होता है, इसमें हम क्या चेक करते हैं, वुंड का असेसमेंट कैसे करना है। तो इसमें सबसे पहले आपको साइज, वुंड का साइज देखना है, लोकेशन है एंड डेप्थ देखना है इसमें, एंड अंडरलाइनिंग कॉजेस देखने हैं, उस किसकी वजह से ऐसा हो रहा है, कि वजह से उसका हो रहा है, कि उसकी साइज क्या है एंड डेप्थ क्या है, एंड कहाँ उसका लोकेशन है, कहाँ वो वुंड हुआ है। नेक्स्ट है वुंड हिस्ट्री। अ डिटेल्ड हिस्ट्री ऑफ द वुंड इज important, including when the wound first appeared, its location, size and duration। wound characteristics। It's important to document the appearance of the wound, including color, depth of drainage or odor। Photographs and wound measurements can also be helpful in tracking changes over time। Wound bed. The type and condition of the wound bed can provide important information about wound healing potential। The wound bed should be assessed for tissue type like granulation, slough, scar, moisture level, and presence of infection। पेरी वुंड एरिया। पेरी वुंड एरिया मीन्स क्या होता है कि जहाँ पे मेरा वुंड हुआ है उसके आसपास कितना अपना स्किन इफेक्ट कर रहा है, उसको बोलते हैं पेरी वुंड एरिया। द स्किन अराउंड द वुंड शुड बी असेस्ड फॉर साइंस ऑफ इन्फ्लामेशन, इन्फेक्शन और डैमेज। जहाँ पे आपको वुंड हुआ है, जहाँ पे आपका कोई लेसेंस है, वहां पे आप कैसे कितना इफेक्ट हो रहा है उसको बोलते हैं पेरी वुंड एरिया। जैसे कितना इन्फ्लामेशन है, क्या क्या इन्फेक्शन कॉज कर रहा है। नेक्स्ट है पेन असेसमेंट। अगर आपको वुंड है तो पेन भी होगा, तो पेन को असेस करने के लिए स्केल का यूज कर सकते हैं। पेन स्केल यूज करने के लिए 0 to 10 उसका नॉर्मल रेंज होता है। 10 में क्या होता है कि बहुत ज्यादा रेयर केस में और या फिर बहुत सीवियर केस होता है जिसको हम 10 मार्क देते हैं। 0 to 10 में पेन स्केल का यूज कर सकते हैं। नेक्स्ट है हेल्थ स्टेटस। A comprehensive health state assessment should be conducted including a review of medical history, medical history, current medication and any comor- comorbid conditions that may affect wound healing. Next है nutritional status. Health status में जैसे मतलब physical examination and history collection. हेल्थ हिस्ट्री में आपका हिस्ट्री कलेक्शन आप पता कर सकते हो कि वुंड कब हुआ, कैसे हुआ, उसका टाइमिंग क्या था। नेक्स्ट है न्यूट्रिशनल स्टेटस है। न्यूट्रिशनल स्टेटस कैन इम्पैक्ट वुंड हीलिंग। इट्स इम्पोर्टेंट टू असेस फॉर माल न्यूट्रिशन इंक्लूडिंग लो सीरम। अगर आपको वुंड हुआ है उसमें आपको सबसे ज्यादा क्या मतलब लेना चाहिए डाइटरी पैटर्न में, तो उसमें प्रोटीन जो होता है वो बहुत ज्यादा लेना चाहिए जिससे कि आपका जो वुंड है वो हील हो सके। नेक्स्ट है मैनेजमेंट ऑफ द वुंड। देयर आर सम की। फर्स्ट है पेन मैनेजमेंट। Pain control is a crucial aspect of palliative wound care. Pain can be managed with various medications, including opioid and non-opioid medications. अगर आपको पेन हो रहा है तो उसमें आपको मेडिसिन प्रोवाइड किया जाए जिसमें कि हम दो तरह के मेडिसिन यूज कर सकते हैं, ऑपॉइड एंड नॉन ऑपॉइड मेडिसिन। एंड नॉन फार्माकोलॉजिकल इंटरवेंशन, इट्स लाइक नर्सिंग इंटरवेंशन सच एज पोजिशनिंग, लाइक पोजिशनिंग प्रोवाइड कर सकते हैं, रिलैक्सेशन टेक्निक्स यूज कर सकते हैं एंड डिस्ट्रैक्शन यूज कर सकते हैं। गिव एन एक्स्ट्रा डोज ऑफ पेन मेडिकेशन हाफ एन आवर बिफोर ड्रेसिंग। अगर किसी को वुंड हो रहा है तो उसके ड्रेसिंग से पहले उसको हम ये मेडिसिन प्रोवाइड कर सकते हैं आधे घंटे पहले। नेक्स्ट है प्रीवियस ड्रेसिंग मटेरियल शुड बी सोक्ड एंड। इसमें क्या है कि अगर हमें पेन हो रहा है बहुत ज्यादा तो उसमें जो ड्रेसिंग होती है उसको हम उसको रैप करके बांध करके थोड़ा सा उसका पेन को कंट्रोल कर सकते हैं, उसको अपने नॉन फार्मास्यूटिकल मेथड में यूज कर सकते हैं। Another method is the use of non-stick dressing. Maintaining the wound in a moist environment will reduce dressing adhesion and protect exposed nerve endings. Pain can be kept in check using a dressing material requiring less frequent change. Irrigation of the wound with saline rather than cleaning with a gauze swab will reduce pain. अगर आपको लेसन से वुंड है तो उसको क्या कर सकते हैं कि हम स्वैब न लगा के हम उसको सलाइन से क्लीन कर सकते हैं या फिर वाटर से क्लीन कर सकते हैं। उसको जरूरी नहीं कि आप रब करें स्वैब से, गॉज स्वैब से। कम्प्लीमेंट्री थेरेपी सच एज हम प्रोवाइड कर सकते हैं, रिलैक्सेशन थेरेपी वापस उसको प्रोवाइड कर सकते हैं। डिस्ट्रैक्शन और विजुअलाइजेशन कैन प्ले इंपॉर्टेंट पार्ट इन द पेन मैनेजमेंट। Management of the malignant wound. The proper approach to the management of malignant fungating wounds shift from healing to addressing quality of the life. अगर किसी को वुंड हुआ है तो हम उसको ट्रीटमेंट क्यों करता है कि किसी पेशेंट को एक प्रॉपर उसकी लाइफ को हम अच्छे से प्रोवाइड कर सके, उसको केयर दे सके, उसकी लाइफ को वापस रिकवर कर सके। इसमें पहले क्या आता है, वुंड क्लीनिंग आता है, ठीक है। फर्स्ट है क्या है, अनलेस अदरवाइज इंडिकेट द फ्लूड ऑफ फॉर क्लीनिंग इज नॉर्मल सलाइन। जैसे कि हम पहले वुंड अगर किसी को चोट लगी है तो वुंड क्लीन करते हैं, सबसे पहले क्या करते हैं तो वाटर से उसको टैप वाटर से साफ करते हैं या तो नॉर्मल सलाइन से साफ करते हैं। नेक्स्ट है क्लीनिंग इज द बेस्ट अचीव्ड इफ पॉसिबल बाय श्योरिंग द वुंड। नेक्स्ट है स्वैबिंग कैन बी पेनफुल एंड ट्रॉमेटिक एंड शुड बी अवॉइडेड। जैसे कि बताया कि आप उसको रगड़ेंगे तो उसको पेन होगा, इससे बेहतर है कि हम उसको नॉर्मल सलाइन या वाटर से क्लीन करें। मैनेजमेंट ऑफ द माल एडोर। माल एडोर इज वन ऑफ द मोस्ट distressing problems associated with the fungating malignant wound. द यूज ऑफ टॉपिकल मेट्रो, अगर माल एडोर है, अगर बहुत ज्यादा स्मेल है किसी वुंड में, तो उसमें हम क्या प्रोवाइड कर सकते हैं, ये मेडिसिन उसको दे, ताकि उसको जो स्मेल है उसको कंट्रोल कर सके. मेट्रानिडाजोल in the fungating wound avoids the side effects like nausea and vomiting normally associated with the oral metronidazole. जैसे कि वॉमिट फीलिंग हो रहा है, नोजिया रहा, तो उसको मेट्रोनिडाजोल दे सकते हैं. नेक्स्ट है laboratory studies suggest that 0.8% metronidazole is active against a range of microorganisms, not just the anaerobic species with which malodor is most generally associated. नेक्स्ट वन इज द ड्रेसिंग विथ चारकोल फॉर्म ड्रेसिंग हनी पपाया. अगर उसको बहुत ज्यादा स्मेल आ रहा है उसके वुंड से, तो उसको हम ड्रेसिंग में यूज कर सकते हैं, चारकोल ड्रेसिंग दे सकते हैं, फॉर्म हनी पपाया एंड मेनी अदर होम रेमेडीज प्रोवाइड उसको दे सकते हैं. मैनेजमेंट ऑफ द एक्सोडेट, जैसे कि कोई ऐसा आपको लेजन्स है, प्रॉब्लम हो रही है एक्सोडेट में, तो उसमें क्या क्या मैनेज कर सकते हैं. फंगेटिंग वुंड ऑफन प्रोड्यूस मॉडरेट और लार्ज क्वांटिटीज ऑफ exudate as a result of increased permeability of vessels within the tumor and the action of bacterial enzymes. Unless exudate is control related problems such as swelling, peri-wound macerations, leakage and odor will be effectively managed. अगर लेजन्स है जिसमें कि बहुत ज्यादा बोलते हैं ना कि पानी भर गया है या फिर गिर रहा है, उसके लिए हम ये फोम ड्रेसिंग इस्तेमाल कर सकते हैं. मैनेजमेंट ऑफ द पेन ड्यूरिंग ड्रेसिंग चेंजेस कैन बी मैनेज्ड बाय लोकल एंड सिस्टेमिक एजेंट्स. लोकल एजेंट्स में आता है आपका लिग्नोकेन 1% एंड सिस्टेमिक में आपका आता है ड्रेसिंग एंड क्लीनिंग वुंड्स. सिस्टेमिक में क्या आता है कि जो होम रेमेडीज हम यूज करते हैं उस, और लोकल में आता है आपकी मेडिसिन लाइक लिग्नोकेन. नेक्स्ट है मैनेजमेंट ऑफ द ब्लीडिंग. Bleeding occurs mainly during cleaning and dressing removal and also due to the other traumas. अगर आप कोई प्रॉब्लम हो रही है या फिर बहुत ज्यादा किसी को ट्रॉमा है, कोई इंजरी हो गई, तो उसमें ब्लीडिंग बहुत ज्यादा होता है, उसको हम कैसे मैनेज कर सकते हैं. नेक्स्ट है प्रोफ्यूज ब्लीडिंग में occur sometimes due to alteration of large vessels. The patient and family should be informed if there is a chance of bleeding. Use of green or red towel during severe bleeding may be useful to decrease the anxiety. अगर आपको बहुत ज्यादा ब्लड हो रहा है, ब्लड लॉस हो रहा है, तो उसके लिए क्या कर सकते हैं कि वहां पे हम टॉवल बांध सकते हैं. नेक्स्ट है द ड्रेसिंग शुड बी सोक्ड विथ नॉर्मल सलाइन, या फिर बहुत ज्यादा ब्लड हो रहा है तो उसको भी हम सेम चीज से पानी से या फिर नॉर्मल सलाइन से उसको वॉश कर सकते हैं. नेक्स्ट है अगर ब्लीडिंग बहुत ज्यादा हो रहा है तो उसको हम प्रेशर देके भी कंट्रोल कर सकते हैं. अगर हाथ पे हो रहा है या फिर पाँव पे, किसी बॉडी पे हो रहा है, तो उसको हम क्या कर सकते हैं, बांध के उस ब्लीडिंग, उस जगह पे जहाँ ब्लीडिंग हो रही है उसको रोक सकते हैं. नेक्स्ट है लोकल एप्लीकेशन. अगर बहुत ज्यादा भी ब्लीडिंग फिर भी कंट्रोल नहीं हो रहा, इतने से करने के बाद, तो फिर मेडिकेशन हम उसको प्रोवाइड कर सकते हैं, लाइक इटामासाइलेट एंड ट्रेनक्सामिक. ये मेडिसिन है जो कि हम उसको प्रोवाइड कर सकते हैं अगर बहुत ज्यादा ब्लड लॉस हो रहा है तो. पेशेंट सिनेरियो ऑफ द सुकुमार. एक पेशेंट है जिसका नाम सुकुमार है, उसका सिनेरियो है we managed his breathlessness, constipation and nausea. He was moving his bowel regularly, his nausea had settled and his sleep too had improved. Next one is his family informed the SCT that he was talking irrelevantly and the sleep was disturbed. He was accusing his wife of plotting to poison him. It was understood to be due to disturbed day-night rhythm and disorientation seen in early delirium. We did not start any sedative. His distraught and devoted wife was explained the cause for his behavior and educated regarding non-pharmacological input as described above. His haloperidol haloperidol dose was stepped up. HCD followed him up and found his symptoms resolving. He and family would continue to require regular cares of inputs and communication based on the progress of his renal failure and other concerns that come up. They may need assistance in decision making for ep- acute episodic issues and in understanding the prognosis and course better. Next one is the stoma care. Stoma care means क्या होता है? Stoma means क्या होता है कि it is an hole of opening. It is the uh, opening of the abdomen or any lower area. Stomas may be temporary or permanent. ये एक सर्जिकल प्रोसेस है जिसमें कि हम होल करके पेशेंट का जो भी भोजन सॉरी जो भी प्रॉब्लम्स है उसको सॉल्व कर सकते हैं. नेक्स्ट है फॉर पेशेंट विथ लॉन्ग टर्म स्टोमास द गोल ऑफ होम पैलिएटिव केयर नर्सिंग टीम इज टू असिस्ट द पेशेंट केयर गिवर. इसमें दो टाइप के स्टोमास आते हैं. फर्स्ट है इनपुट, दूसरा है आउटपुट. है इनपुट में ट्रैकेस्टोमी आता है, गैस्ट्रोस्टोमी आता है. आउटपुट में कोलोस्टोमी एंड इलोस्टोमी एंड यूरेट्रोस्टोमी. ट्रैकेस्टोमी द पेशेंट एंड केयर गिवर शुड बी. ट्रैकेस्टोमी मीन्स क्या होता है? ये एक इंसिजन है, एक प्रकार का इंसिजन जिसमें कि हम ट्रैकिया में करते हैं. The patient and caregiver should be counseled on the daily cleaning of the inner tube which is to sterilize in case of metal tubes. अगर ट्रैकियोस्टोमी किसी को हुआ है किसी पेशेंट को, तो जो उसमें लगा होता है ट्यूब, उस मेटल ट्यूब लगा होता है उसको क्लीन कर सकते हैं. नेक्स्ट है द आउटर ट्यूब should not be removed. Gentle sterile suctioning in case of heavy secretion. The skin should be protected with gauze placed in the interface between the tracheostomy and skin surface. ट्रैकेस्टोमी अगर किसी पेशेंट को हुआ है तो जो अंदर से जो उसको of the patient caregiver surgeon of the patient caregiver surgeon home care nursing team patient concerns such as skin issues, diarrhea, constipation, prolapse, bleeding must be assessed and treated with dietary modification, medications, and referred to higher center if require any surgical intervention. Example में 1.5 centimeter in colostomy, 3.5 centimeter in ileostomy, stenosis, bleeding which is not controlled by local measure. Patients with stromas do well with psychosocial supports and counseling to encourage them to lead normal active lives. Next, management of the emergencies in palliative care. Commonly encountered emergency in the palliative care of patients with progressive metastatic malignancy are spinal cord compression, hypercalcemia, superior vena cava obstruction, hemorrhage, and seizures. Spinal cord compression. The symptoms and signs may be subtle and require an index of suspicion if prior knowledge of spinal involvement is not available, like back pain, weakness, stiffness, incontinence, retention, radiculopathy, spasticity may be seen. The patient may manifest of upper motor neuron or lower motor neuron signs depending on the level of lesions. The immediate measures are to administer steroids. अगर किसी पेशेंट को बैक पेन है या फिर स्पाइनल कॉर्ड कंप्रेशन है तो उसको हम क्या प्रोवाइड कर सकते हैं? स्टेरॉइड प्रोवाइड कर सकते हैं. उसमें हम डेक्सामेथासोन दे सकते हैं. hypercalcemia. This is the most common metabolic emergency noted in patients with malignancy. It is either due to bone metastasis or due to paraneoplastic syndrome. Early symptoms of nausea, vomiting, polyuria, thirst, constipation give way to confusion, delirium, severe dehydration, cardiac arrhythmias, ileus, and death if not recognized and treated in the time. Superior vena cava obstruction. This phenomenon occurs in tumors affecting the mediastinal structure adjacent to the superior vena cava. The superior vena cava can be obstructed by extrinsic compression or from thromba or tumors within the lumen of the vessels or by invasion of the wall of vessels. The patient is breathless, appears plethoric with dilated vein over the chest and neck and may complain of blurring of vision, headache. Immediate administration of steroid 12 and 16 mg of dexamethasone. In case of breathlessness, priority should be given to ensure stabilization of the airway to prevent acute respiratory failure. Using of clothing propped up position and non-pharmacological measures should be also be done while airway straining are treatment options available in specialized centers. Next one is the hemorrhage, loss of bleeding. Hemorrhage from tumor invasion or from coagulopathy or thrombocytopenia in patient with malignancy is seen in 10 to 15% advanced progressive malignancy. Immediate measures to control local bleeding is pressure, local infiltration with saline adrenaline solution. Next, tranexamic acid can be given in instances of homeoptysis or hemoptysis. In case of hemoptysis, if the site of the lesion is known as, then the patient is advised to lie on the side of the lesion. Cough suppressant like codeine or low dose morphine can be given. Inhaled nebulization should be avoided. Ethoxylate can be used in bleeding tumors. IV fluids can be given. Small dose of anxiolytics can help the anxiety. Use of dark linens to reduce the distress experienced by patient and caregiver at the site of blood is encouraged. Seizures. Seizures may be seen in patients with malignancy affecting the brain, brain metastasis due to intracranial bleed or due to metabolic derangement in patients with malignancy. The emergency care of seizures remains the same with placement in recovery position, aspiration, precautions. Benzodiazepam like midazolam or lorazepam can be used while assessment is done for etiology of the seizures. It is important to determine the need for continued anti-epileptic drug in patients with malignancy and counsel the family on the adherence to the same to prevent deterioration of quality of life. Summary. Describe the management of wound ostomies and emergencies care. Finish the problem of malignant wound, assessing the wound, training the management of wound, demonstrating the scenario about sukumaram, explaining the emergency in palliative care, research related to topic. Conclusion. Palliative care of wounds management, ostomy care and emergencies focus on improving the patient quality of life and addressing their physical and mental health needs. The goal is to provide patient and family-centered care that consider the patient unique needs, values, culture, and preference.
Thank you, Ms. Archana, for your insightful presentation. Thank you, Ms. Archana, for your insightful presentation. Now let's move on to our next speaker, Ms. Divya, who will discuss end of life care.
Good morning, respected principal sir, vice principal ma'am, all the teachers and my dear students. Today I am Divya Pandey from MSc Nursing second year 22-23 batch. I am here to continue our seminar presentation palliative care. So today I am here to deal with the topic that is end of life care. Introduction, like as we know, each individual will experience a different while they are proceeding towards their death. So we can't say that everyone is having the same feeling or everyone will have the same emotional expressions or whatever the stress, depression, whatever things will be won't be same for each and everyone. So each individual, it will be different for everyone. Each person experience at the end of life is different and each individual has a unique need for information and support. Like individual will need a different support, emotional support, spiritual support and care, pampering they will need from their relatives, from the people, their loved ones and nearby peoples or the nurses from those who care for the long duration of time. So usually when you are feeling sick, you need your mother. Like that, when end of life will be there, then the person will need their loved ones nearby them to have a more time with them, because they may be having a feeling that they are going and they need much as time they are having with their relatives. Definition, it is a concluding phase of normal lifespan, although life can end at any age. When we are coming to that, then it will be like at present time, then 60 to 80, it is a lifespan of at present generation, present situation. 60 years to 80 years is a normal lifespan. But death is the one which can be happened at any time. Anytime the disease condition can be occur, life threatening conditions like cancer is there, lung diseases are there, stomach traumas are there, many conditions are there. Like any organs which will have the life threatening condition, it can be occur at any time of life, uh, not only at the end of a lifespan. So it will be same for every same, like we have to care for the patient when it is a end of life. like many, like emotional support has to be there, spiritual support has to be there, and the patient's rights will be there. That the patient who is dying, we like we are thinking a patient is about to die, then we don't have to ask anything to the patient, but they do have right for their own self. We need to ask each and everything, because patient can also withdraw the things. Like if patient, we need to ask the patient whether they want to take that injection or not, whether they want to take that medication or not. They can withdraw, they can stop, they can say no, and they do have the all right to say no for their medication, treatment, therapies, and cure. Why we are keeping it as an important topic as an end of life care? Some goals are there. First is providing comfort and supportive care during the process. Comfort, like they should not feel any pain, they should not worry, they should not emotionally break down. So we need to provide a full time care to the patient who are in their last stages of life. Then improve the quality of remaining life. We can't think that they're dying, then it is okay, don't give daily routine care, don't give this one, don't give their proper bed sheet, and no routine care is needed. We need to like we are living, that time we are having the life with dignity, then death also need to be with dignity. So we need to maintain that the quality of end life also need to maintain for the patients. Help to ensure a dignified death. Dignified, like they should die in a peace, they should not any regrets or anything won't be there. So we need to help out the patient in their end stages as well. Here we'll see the some principles of end of life care. First one is respecting patient goals, preference, and choices. Means we need to ask the patient and we should respect their choices, what they wanted to say, what they want to eat, what they wanted to do, whom they wanted to meet. So these things has to be respected. We should not shout on the patient. We should not disrespect the patient, or we should not say bad word to the patient. These criteria has to be fulfilled, and we should treat a patient like an individual. According to their need, we need to fulfill the criteria for them. Next, attention of the medical, emotional, social, and spiritual need of the dying person using a strength of interdisciplinary resources. Means a full attention has to be given. Symptomatic management has to be done for the patient. If patient is feeling pain, then medications has to be provided, routine care has to be done, then regular visit of doctors has to be done, what they are telling, active listening process has to be there for those patients, and interdisciplinary approach has to be there. Like as a team we are working, then a proper discussion, communication has to be there, and what type of routine care and what are the things, what are the rights we have to do, and how to inform to the patient relatives or bystander, that criteria has to be discussed among the healthcare team, and the proper approach has to be done for the patient. Acknowledging and addressing the caregiver concern means the discussion between the family and nurse has to be there, so we could be know what we have to do, and we could also know aware about what family wants to do, what their culture. So we have to think overall, like holistically we have to think when we are caring for a patient, not only medical side, that we are thinking sometime only medicine we are giving, we are doing our nursing work. That is not enough. We have to holistically think what all over the needs of the patient. So we need to work on those things. Building mechanism and system of support. So throughout we need to be a support system for our patient. It is an emotional support, because patient, he is knowing or condition is getting worse. So many stress or psychologically he may be worsening his condition. Sometimes patient won't be tell. So you need to sit down with the patient, take time with your patient, talk with your patient. So patient get deviated from some things, and that will be the emotional support for the patient. So here we'll see some points like a dying person's bills of right. According to Potter and Perry 2010, adapted from the Barbas age in 1975, the client has right to, even the patient is dying, they do have the right, have a sense of purpose. Whatever we are doing, for what purpose we are doing, they do have right to ask, and they do have right to say no. uh, be cared by those who can maintain a sense of hopefulness. Means like 4 or 5 nurses are there caring for a one patient, and patient with whom the patient is comfortable, with whom the patient need to be cared by, or sometime patient will be tell this care will be given by my relatives only. So we'll accept this thing and will allow the relatives to give the care to the patient. So these things has to be Uh, Next is participate in decision about my care. Means patient do have the right. They can like sometime we used to make patient also coordinated with our care. You took this medicine. These are the medicine like this. You have to go for wash. These all things we need to don't like we are not the nurses. We are doing everything and we are coming back. We are not discussing with the patient. Sometimes they are capable of doing many things. Sometimes we are not seeing the patient and we are giving the sponge bath to the patient, but patient is telling I'm capable of going to the washroom and taking the bath. So these all things has to be need to be discussed with the patient, and their dignity has to be maintained and respectful relationship should be maintained for them. Expect continued medical and nursing attention even though the cure goals must be changed to comfort goals. Cure, previously we do have the focus on curing the patient and preventing the conditions and build up their health status at the optimum level, but at this stage we need to focus on the comfort of the patient. Whatever the symptomatic management is there, we need to provide to the patient whatever the things patient it needed, like some family members they need with them. So we can expand their visiting hours as well, from whom they need the care we can allow them with the patient. So these things we need to take care while we are caring for a patient who are in their end of life stage. Other rights are dying in a peace and dignity. Next one, retain my individuality and not to be judged for my decision that may be contrary to beliefs of others. Means whatever the patient is telling, we should not judge them. We need to motivate them, support them, comfort them, but we should never judge the decision of the patients. Be cared for by caring, sensitive, knowledgeable person who will try to understand my needs and will be able to gain some satisfaction in helping me face my death. This is like a statement from a patient who is telling the one who is helping me, who is understanding me, and who is not judging me. That type person, or we all do need that type of person who is there is a support for you, and no one that person is not judging you. So like that we have to care whomever the patient is. We should not judge the patient at any situation. So next is power of attorney. Power of attorney, it is a legal document that gives someone the authority to act on behalf of another person. It happen like a patient who is on a bed or a life threatening condition or bedridden patient for the long duration of time, and the end of life had been came, like some threatening conditions, then the patient do have the right to give his all authority in a documentation basis. Like for any patient is there, then his grandson is there but they are not caring for them, then other one who is the person who is helping and caring that person, they given that power and authority to them for their business, for their home, for everything, in a documentation basis. When the patient will die, after that everything will be seen by them, or when the patient is there, their health care, how they have how where they have to admit it, how care has to be done, for that purpose only that person will so see. That is known as power of attorney. Next is cultural consideration. As we all belongs to different cultures, we all are sitting here, so we do belong from different culture. We do have different beliefs, values, and way of living, way of clothing, everything is different. So we should not give whatever we are thinking, what from what culture we are belonging, we should not think about that only. We need to consider the patient culture's value, and our care should be according to that. It should not hurt them or it should not disrespect their culture. So we need to consider the culture of the patient. Cultural consideration, we as a nurse need to recognize the client's culture, the nurse culture, and how both affect the nurse patient relationship. From which culture I am belonging, from which culture patient is belonging. First and foremost, our priority should be patient care. Okay, that has to be done, and the realize the cultural background and family practice influence the people's interruption. Sometimes we used to do our things to the patient, but family or relatives will be there, then they will say no, it is not like that, our place it is like that. So we should accept the decision of the family and relative as well as of the patient, and we need to coordinate in the if we are taking any decision, we need to coordinate with the patient as well as family members. Providing comfort for the terminally ill clients. First, the symptom control. Those who are patient, those who are clients who are terminally ill or they're in a last stage, we need to manage them. First is symptom control. Symptom control means comfort for dying patient requires management of symptoms of disease. For example, like symptomatic management, you all know, symptomatic, like patient is having fever, then we have given antipyretic medicine. Patient is having pain, then we had given analgesic medicine. So whatever the patients are having the symptom, we will treat that symptom. So the patient will be in their comfort. Patient won't feel any pain. That will be the peaceful dying. Next is maintaining dignity and self-esteem. When a patient is diagnosed with a terminally ill condition, their dignity and self-esteem decreases. A patient's personal dignity is individualized to them. Here means like if we are came to know that some condition is there that is life threatening condition, it treatable, it is not treatable, like cancer like conditions or lung cancer, lung diseases, some life threatening conditions will be there. Then we started to think there is some problem in myself, I'm not taking care, I like many things we started to think. So at that phase we need to help out the patient, we need to support the patient. Our support is very much needed to enhance, to build up their self-esteem, build up their confidence level. So we as a nurses need to support our patient, need to comfort our patient on those situations. Prevent abandonment and isolation. Like when we'll get some condition or some problem, we'll subside, we'll make ourselves isolated, we don't talk to anyone, we feel like we are not like others, we are odd man out type. We do whole, sometimes we'll fail in examination, then we feel like everyone is good, we are not good. So like this patient will also, when they are diagnosed with any condition, they will feel like that. That time what is our work as a nurse, we should not leave the patient alone, because psychologically many things will be going on the patient's head. It may be the problematic situation afterwards, we need to be with the patient or some relative has to be with the patient, and we should talk to the patient. Don't leave the patient alone without any conversation. We need to discuss what is going on their head, so what we can cure the patient on those situations, or we can motivate the patient, or we can give some solutions. So this situation has to be tackled like this. Next is providing comfortable and peaceful environment. Comfortable, holistically we have to work, and comfort we need to think. The proper rooms has to be there, peaceful has to be there, visiting hours proper should be there. Whatever they feel to eat, there will be our wish now, like some best dishes, what we like the much. That things should be asked, and that should be provided to the patient where they want to visit nearby, like in a hospital, garden area will be there. So we need to with the patient, and we need to discuss all over the comfort we need to provide at the end stages of life to the patient. Next is address fears of dying and death. People are afraid of dying and death for many different reasons. The process of dying with it associated with the pain and loss of dignity, not knowing what will be happen after death. Like everyone is having fear of death or getting ill or getting any operation. So everyone is like a stressful condition for patients as well as for the family members, relatives, and their loved ones. So in this situation, because when the patient is in their life end of life situation, we cannot control everything, but at least we can comfort the patient, we can make those days happy for the patient, and it could be a dignified life for the in few days of the patient. How to get family involvement in the care. The family can be the primary caregiver for the client preferred. Means usually if a child is there or an adult is there or anyone is there, we need our family every time. So family should be involved for caring the patient, like basic care, what routine care we are giving. In that we can teach the patient. Nowadays, like family members and patient as well teach for to take their insulin injection by own. They don't have to visit every time to the clinic or the physician. They can take by own self. Like that we need to teach something which is having the rational, which is having the evidence. So those practice, because we are whatever procedure we are doing with an evidence, we do have the rationally for every procedure. So on that we need to teach the family member how to do any procedure, any basic care, so they can also coordinate with us while doing the care for the patient, so it will be very comforting for the patient. Discuss activity other family members are involved in. Like whatever we are planning to do for the patient, we need to consult from the patient, as well as informed consent has to be taken from the family member, whether they want to do anything, whether they knows patient well, better than us, so they know what makes the patients happy. Those things can be discussed with the family, and those approach has to be achieved by the family in coordination with the patient as well as with the healthcare professional. Find some simple and appropriate care activity for family to perform, like some basic procedure. Just for example, oral hygiene. Patient, relatives or family can help them to do. Daily bath can be done. Hair washing can be done. So these are the basic things which family member can do for the patient. Bring in pictures, cherished objects, cards, and letter from the family members and friends, plants and flowers. Like to make a day of a patient a good day, like we can some surprise visiting of the relatives, some greeting cards from the family and friends, some flowers, some bouquets on a routine basis. So we make the days of the patient as a cheerful and memorable for them, so they can feel happy. Nurse teaching strategy for family involved. Describe, demonstrate the feeding as I had been discussed, like rice tube feeding and the basic routine care. We should demonstrate once to the family member, and those who are willing to do, those patient is feeling okay with their relatives care, then we can involve the family member for those basic procedures and care. Now we'll move toward the physical changes nearing the death and associated definition. As patient is moving toward the process of death, then some sign and symptom can be seen in the like physical changes can be seen in the patient. These are: first is mottling. Mottling is near death circulation will decrease, and the patient will have the patchy blue color discoloration on the body due to reduced circulation, and the movement will be decreased. Patient will be slow down. So this will be the picture, like some patches will be appear on the patient body, and it will be purple bluish color patches will be present. That is known as mottling. Next is rigor mortis. Rigor mortis, maybe you had been studied. It is a stiffening of the body when the patient was the death. So the stiffening of the body prior to death as end of the life approaches and undergoes the metabolic changes. Process of rigor mortis includes the paralysis of the jaw. The jaw area will get paralyzed, means it won't be moved. Loss of facial tone, reduction of gastrointestinal motility, and peristaltis, suggestion of the bowel movement, and decreases of the urinary function. So rigor mortis is simple. It is known as stiffening of the body. And what are things will be there? The body activity, the system functions will also be stopped. Next is short. Short is like we need to arrange the things after the death, how we need to pack or everything. For that, sheets like garments for wrapping corpse of burial, covers, conceal, support, and disguise the body in burial. For burial process, how we need to arrange the thing, those all this is known as. Next is kinestroke. Kinestroke, it is abnormal pattern of breathing characterized by altering period of suspended breathing and deep rapid breathing or no breathing. Means it will alteration or abnormal breathing process will be there. Sometime patient won't be having any breathing. Sometime it will be very high or rapid breathing, or sometime it will be very slow breathing. Physical changes like sleep disturbance, different pace, circulation changes, circulatory changes will be there, and bowel function changes because it will be have a stiffening, and peristalsis will also stop. Then all the motility will be stop, and eyes, hearing, and a patient who are approaching towards their hearing capacity will. Breathing changes, rate will slow drastically with the breaths become faster apart. As death goes approaches, breathing may become labored with the person gasping for air. A death rattle may be present and the sounds like a low throat. Breaths will slow and come further and further apart until the final breath is taken. So there will be a cessation of breath in between, then a deep breath will come. So this is a process of breathing until the last breath has been come. So here we'll see the different care at the end of life. So three main cares approaches are there, what we have to do for the patient at the end of life care. These are uh, palliative care, hospice care, and spiritual care. So with all these, we need to holistically support the patient at their end of life. First is hospice care. Hospice care is a concept of caring, provide like holistically we need to provide comfort, compassion, concern and support for the dying patient. Some principles of hospice care are: death must be accepted, total care managed by multidisciplinary team, like multidisciplinary healthcare providers has to be maintained and managed, and proper support and care need to be provided. Pain and other symptoms of the terminal illness must be managed, like we had been talked about, symptomatic management has to be done. Patient and family views as a single unit of a care, means when patient and family together has to work with the healthcare professional, so they will be look like a team, they will be look like a family for the patient. Home care of dying necessary, like some person want to visit their home and everything, so this has to be accepted. And bereavement care of family members, means grief and bereavement is there, so that time has to be provided to the family members and relatives. Hospice care focuses on the whole person, not only on the medical condition or anything. It will be work on a whole person, mind, body, and spirit. Support and care the patient's family caregiver continue after the death of the patient. As the patient is dead, we also need to support the family members, as they are going to emotionally going to break down as they are losing their loved one or family member. We also need to take care of the family member after the death of the patient as well. Function of the hospice team: develop the a plan of care. What they have to do, they should have a proper plan outlet. Manages pain and symptom, attend to the emotional, psychological and spiritual aspect of dying, teaches the family how to provide care for the patient, advocate for the patient and family, provide bereavement care and counseling the family. Next, we'll see palliative care. Palliative care is an, from the first day starting, we had been discussed about the palliative care. Palliative care is an approach to care that improves the quality of life patient and their families, those who are facing the life-threatening condition. When they are diagnosed with the life-threatening condition, that situation, how we have to provide the care, medical care, treatment, management support, psychological support, emotional support to the patient, that is overall known as palliative care. Principles focus on the quality rather than the quantity of life. We are providing the support, care. So it should be comfortable according to the patient situation. Life affirming but death accepting, effectively communicating at all the levels, whatever things are happening, we need to properly communicate with the patient as well as to the family members. Respect for autonomy and choice. Their choices, their decisions has to be accepted by the healthcare professional. Holistic multi-professional approach should be there, caring about the person and those who matter to that person, like family member, relative, any friends are there, any loved ones are there, so we need to consider all of them for caring a patient in a last stages. And recommended for patient with the rapid progressive disease, palliative care is recommended for the patient those who are in rapidly progressive diseases. Then patient with a disease presenting unexpected, difficult to control or rapidly progressing symptoms, distressing symptoms when no relief has been achieved within 48 hours of time, psychosocial distress in patient or family relating the diagnosis or facing the death. So whereas reassurance of second opinion is sought by the patient, family or the other healthcare professionals. So this point has to be considered, and if any good places are there, that reference has to be done, and proper multidisciplinary approach had to be accepted, and care has to be fully provided to the patient. Philosophy of palliative care should be available to anybody with a life-threatening illness. Focus of care is quality of life with the autonomy and choice of the patient being unheld. Then care is extended to both the patient and those who matter to him, means the family members and the relatives. A whole system approach is made when the planning care with the patient. the holistic care should be provided. Not only we have to see on the hospital, but everything we need to see their psychological, their emotional. We need to talk and discuss with the family member as well as with the patient on that situation or condition. Next, we'll see about the spiritual care. Spirituality means features of religiosity, but the two concepts are interchangeable. Spirituality involves the search for meaning and purpose in life and relatedness to a transcendent dimension, like how they are thinking, what they want to do. So, spirituality, how do we believe? How we have to do those things also, we need to do care for the patient according to their belief and culture. Aspects of end of life: palliative care, preparation of end of life, care for the terminally ill child or adult patient, hospice care, advanced directive, understanding the CPR and DNR. So here last we'll discuss about the types of grief and grieving. So already we had been discussed in many presentations from yesterday till now. That first I'll discuss about the there are the many types of grief according to Potter and Perry 2010. So first is normal grief. Normal grief, when we are losing any loved ones, consists of a normal behavior reaction to the loss and symptoms. Like it will be sadness will be there. Sometimes the person will not talk to anyone because they lost the loved one. Second is anticipatory grief. Anticipatory grief means process of letting go before an actual death has been occurred. If we had seen that any family member is very terminally ill and this, then we'll lose the hope and we'll say like letting go. We in our mind will think like okay, he will be dead only. So that is known as anticipatory grief. Next is complicated grief. An individual has troubled progression through the normal, that process will be long and that will be long for that. Next is uh, disenfranchised grief. People experience grief when a loss is experienced and cannot always be openly acknowledged. Means when the loss, actual loss is happened, after that they will accept it, but they won't be acknowledge it or talking to everybody or long explanation won't be there for this. So according to Kobler-Ross, 5 stages of grief are there. So these are 5: denial, anger, bargaining, depression, and acceptance. Denial: individual behave as though they have not experienced a loss, or they will not accept. This can't be happened to me, or this is not happening. This is not real. Next is anger. Individual will try to cope but punishing away the loss. Means they will have the anger, why God is doing to me only, why this is happening to me. The response will be the anger form. And the bargaining. Individual will believe that there is a way for prevent this loss. So they will try to accept and they will bargain with something else why this is happening. And depression, the individual will finally feel the full force on the loss, like as something beloved or anything is lost, they will have in a depression phase or they will think emotionally depressed, they will be there, and at the end they will accept the situation. Individual will accept the loss and start to think about the future, and the life will goes on the same track. Then next is Wally by the phases of mourning. There are the 4 stages. Numbing, numbing, feeling stern or unreal can be interrupted by the periods of intense emotions. Hearing and searching, full effect of acute distress, emotional outbursts, and uncontrolled crying will be there in the person. And disorganize and disappear. Evaluation of loss, maybe become angry at perceived person at the fault. Reorganization, person begins to move forward with the life, roles, skill, and relationships after accepting the loss. Modern 4 task for mourning. Task 1, to accept the reality of loss. Task 2, to work through the pain and grief. That is pain and grief. It is a normal stage. Every person will go through it. And task 3, to adjust to the environment in which the disease is missing. And fourth task is to emotionally relocate the disease and move with the life. So these tasks. So what is dignified dying? Dignified dying means a natural death free from available distresses and suffering for patient, family and caregiver by the wishes of patient and families and consistent with the clinical, cultural and ethical standards. Dignified, the patient will have all the comfort, no pain, no any stresses, no any problems. So like they will have a discussion with the family, talk with the family, relatives are nearby, they are being comforted by the healthcare professional, proper care, systematic management had been given. Conversation, whatever they wanted to have at their right last time, they had it had been provided to them. So here one supportive systematic research study which had been conducted by the Presti MA Demand F Gold HTN on the end of life care for the people with the cancer from ethnic minority group J. Hobbs Palliative Care. It was published in the year 2014 in December 29. In this, 25 studies were included, 20 quantitative and 5 qualitative studies were there. All had a full text English language article that focused on the ethnic, racial minority group of African Americans or the Asian American. In the conclusion, the end of life care differences among the ethnic racial minority cancer patients were found in the process, preference and beliefs regarding their care. Further steps were needed to explore the exact causes of differences. Yet possible explanation included religious or cultural differences caregiver means according to this study the further more study like full conclusion is not there, so further more studies also can be done on this according to this research study. So in as we know, the end of life is also should as we are living. We should not discriminate that a patient is dying, so we don't have to do anything. Proper caring, management, that treatment, support, emotional support, family conversation, information, and coordination care of the patient has to be done as the nurses. We are if we are providing care to the patient in so far we had been discussed about end of life care. In that we have been the introduction definition of end of life care, and we had been the goals, principles, and what will be the physical changes a patient is seeing at the end of a life care. And we had been seeing the stages of grief and bereavement, and how we have to care end of care patient rights also we had been. So it was all about my today's session. Hope this was knowledgeable and helpful for you in the future. Thank you everyone for listening.
Thank you, Ms. Divya, for your informative presentation. Now, let's move on to our next speaker, Ms. Shivani. She will discuss the topic of drugs in palliative care.
Morning on principal sir, dear principal ma'am, all teachers, as well as my dear students. My name is Shivani Shukla from MSc Nursing first year, 2024-25 batch. Today, my intra-college seminar. Before my topic, I'm going to start with queries. Unable to differentiate between medicines and drugs, and
Drug is the pure form, and medicine is the combination of the drugs.
okay, medicine curative purpose and drug altered our body mechanism. So, we start, introducing my topic. My topic is drug in a palliative care. Introduction. Introduction of a drug in palliative care. Before drug in a palliative care, you know about what is palliative care, how to communicate our patient, what is all those things, how to manage all these things. So then we have to discuss drug in a palliative. Palliative care is a specialized form of health care aimed at providing relief from the symptoms and suffering serious chronic or terminal illness. Those patients are suffering from the serious chronic or terminal illness, at that patient provide the drug. Patients receiving palliative care can have a many different symptoms, like symptoms like they are suffering from the pain or nausea, vomiting, restlessness, or any other symptoms they are showing. Then we have to provide the symptomatic medications to our clients or a patient. Pharmacological intervention play a crucial role for achieving the goal of the patient. Drugs used in a palliative care are aimed at reducing the pain and manage the nausea, vomiting, and reducing the depression of the. That's all about my the introduction. So let's we discuss about the 10 top most commonly drug which we in a palliative care setting at the worldwide level. Drugs we are using for the palliative care, but this is the top 10 most commonly drugs which we are using for the palliative care at the worldwide level. First is non-opioids analgesic, second is opioids analgesic, and third is a laxative, fourth is a antipsychotic, and fifth is a sedative, antiemetic, and seventh is a gastric protection agent, eighth is a corticosteroid, ninth is the antidepressant, and tenth is the anti-infective drugs. So the graph I mentioned that how the drugs are using palliative care. Drugs and their actions. First is a non-opioid analgesic. For example, acetaminophen and NSAID. Non-steroid anti-inflammatory drugs which are used in a mild to moderate pain. So patient is suffering from mild to moderate pain, then we are using opioid analgesic. Third, second is the opioid analgesic. For example, morphine and fentanyl are the cornerstone of the pain. For the severe pain, having severe pain, administer the morphine to the patient, and morphine is the opioid drug. Laxative, for example, methyl cellulose are used to the constipation. Sometimes patient have a constipation. Laxative. Antipsychotic drugs, for example, haloperidol to manage the delirium. Sedative drugs like lorazepam are used to reduce the anxiety of the patient, because patients have so many symptoms. Patient on a last end of the life stage have a so many anxiety. Sometimes patients have anxiety, but they are not a response. They are not feel their expression. So we have to administer the sedative drugs for comfort of the patient. Second, and next is the antiemetic drugs. For example, dexamethasone are used to manage the nausea and vomiting. Next is the gastric protection agent. Pantoprazole and omeprazole are used stomach lining caused by the ulcer, because patients are not able to take properly. So the patient's stomach have so much acid that affects the stomach lining and causing ulcer. From preventing ulcer, we are using the gastric protection agent. Next is the corticosteroid drug. For example, dexamethasones are used for anti-inflammatory effect. Antidepressant drug used for patient that example is selective serotonin reuptake inhibitors are used to manage the depression of the patient. The anti-infective drugs, amoxicillin or ceftriaxone are used for anti-inflammatory purpose because patient have a inflammation also. Next, I'm going to discuss evidence-based study related drug in a palliative care. This retrospective cohort study was conducted by the Massman, DA, and Von Dick M. et al. At the Lawrence Cadenza in Rotterdam, the Netherlands. This is the largest palliative care center in the Netherlands, where 208 patients are annually admitted for the palliative care. This study aimed to evaluate drugs were administered and what doses and route of administration from admission day of death in a patient admitted to a single palliative care. So this study we know what drug we are going to administer to our patient, what is the doses of the drug and which we are going to administer to the at the day of admission to the day of death. Next, the study show that the most commonly prescribed medicine on the day of death for the patient in the biggest palliative care facility in Netherlands were morphine, midazolam, and haloperidol. These medications are highly statistical, significant higher doses than those on the day of admission. It when we are taking your patient or we are admitting your patient at the day, we are starting with the slow reactive medicine, but while doing the patient is prolonged care, the medicine doses are increasing. Then at the death day we are providing these drugs to our patient because these are high reactive. Almost 90% of the patients give oral medication at the time of the admission. When we are admitted the patient, they are able to take medicine by oral form because they have a capacity, they have a efficiency that they take medicine orally. They are able to swallow, but prolonged treatment patient have no capacity, patient are not able to responding at the time we are providing the medicine the subcutaneous. So here we say that almost 90% of the patients oral medication at the end
Some technical problem due to arise after that is start some after later that is start our session. Wait, please wait.
Hello, hello, hello.
Hello. Sorry for disturbing you. Just because of technical issue, I have to stop my session. Now I'm going to start again. So some guidelines follow while storing the medicine. As a picture, you see that how to keep the medicine according to temperature, light, humidity, and air. If we keep the general medicines, we have to follow the 18 to 25 degrees Celsius. And if we keep a refrigerator, then we have to 2 to 8 degrees Celsius. We have to follow light. Some medicines are very sensitive in light because direct exposure to sunlight or normal light also they have to destroy their potency or efficiency of the medicine, so we have to keep the medicines away from the light. Next is humidity. Do not store your medicine at the humidity place where it means if you make a storeroom for a medicine purpose, then you have to make away from your like bathroom or any other place where humidity is not reachable. So dry place is necessary for the keeping the drugs. Next is air. If we keep a medicine, then we have to keep the airtight container where air is not coming inside before it start to consume. Guidelines follow while storing the medicines. Medicines must be labeled and placed in its designated place. While you are going to store your medicine, then you have to label your medicine.
So some guidelines followed while storing the medicines. Medicines must be labeled and placed at the designated location. Next is cross check that essential medicines are available against a master checklist. While you have to keep your medicine in a storeroom, then before distributing or after administering the medication, you have to cross check with the master checklist that your medication stock is available in the storeroom or not. So medicines rack is categorized. Medicines rack is categorized according to the alphabetical order. Because if we arrange your racks in alphabetical order, it is benefits for you, because sometimes very suddenly emergency is coming, and at that time we have to, if we are label your medicine in alphabetical order, like we have to, we want amoxicillin, then it's come A. First we have to go at the rack where we put the A. That time we have to not identify where I keep the medicine. So we have to keep medicine in a storeroom as a alphabetical order for our easy approachable. Tablet and capsule must be placed in a separate containers. Tablets and capsule we have to keep in a separate container, and medicines for internal intake and external use must be stored in a separate racks. Internal intake means which medicine you have to give to the patient in oral form, that you have to keep in a separate rack, and which medicine you have to give the patient in a topical form, like any ointment or cream, that we have to keep in a separate rack. Next, label placed on a container top. If we have to keep any labels on any bottles or any envelope or any rag cupboard, then we have to keep that label on a top. It because it reduces the error of a human being, because when we see anything, we see the top of the things, then we are easily know and easily identify that what drug we want and easily approach that drug. If the change in a color, shape or smell is noticed in a medicine, then it must not be distinct. If any color change, if any smells are changed, medicines we are identified, then this medicines we are not going to distribute, or we are not going to administer to your patient. Next is emergency medicines should be stored, ensuring visibility and quick access. Emergency medicines we keep in a easily approachable place, because emergency at the time when we have an emergency, we have for not wandering and here and there. If we keep emergency drug in a glassware container, then we have to easily find that drug and administer to the patient, and we have to prevent from any harmful impact or any critical condition. The required storage temperature for medicine must be on table. If we have any medicines, then what the temperature they need at the things we have to label on the top of the labels. While distributing medicines or administering to the patient, nurse should explain the purpose of medicine, doses, medicine intake time to the patient, then mark the same on next, recheck that medicines being distributed match with the prescriptions. While you're going to distribute or administer the drug to the patient, firstly you have to recheck with the doctor prescription. As per the doctor orders, we have to administer the drug, and cross checking is very necessary before administer the drug. Maintain a register of medicine distributed to the patient. You have to maintain record and report. Documentation should be very necessary while you administer the drug, because your documentation show that which time you administer the drug to the patient, what the doses you use, how much quantity you are using, and which drug you are administered to the patient. So register should be maintained. The storeroom of medicine must always be maintained logged with limited access for authorized people. So, because storeroom is not any illiterate person is handled. Those who are handling the storeroom, that is authorized people and have locked in a storeroom. Next is the safety measures while handling the medicines, or cross verify and matching before the administering the medicines.
before going to administer, we have to cross check and verify all these things. And these are the 16 rights of the medications, like right medicines, right patient, right time, right doses, right route, right documentation, right history and assessment, right drug interaction, right education, right refusal, and right evaluation, right principles of care, right reason, right prescription, and right nurse clinician, and right approaches. These are 16 right you have to follow during administration to the medication to your patient. Next is safety measures while handling medicine. Medicine must be administered or distributed strictly as per the authorized doctor prescription. In case of any doubt on the prescription, get it clarified from the relevant authority before administering to the patient. If which medicines you are going to administer as a staff, then we have to check that medicine is prescribed by the authorized doctor. It means MBBS have only authority to write the medicine. No, otherwise no any nursing practitioner or any staff no have any authority to prescribe the medicine. So we have to cross check. If any doubt regarding the medicine, then you have to call that person, that authorized doctor, and clarify your doubt, then you go for administration. Nurse must be educated about the minimum doses and maximum doses of each medicine that they handle. Nurses are going to handle the medicine, they have to know that what is the minimum dose of medicine we are going to administer to the patient, what is the maximum dose of medicine. Medicine should be distributed at the right intervals. Right intervals, it means some medicines have a duration is 6, action duration is 6 hours. Then after 6 hours, immediately we have to administer that medication to the patient. If the duration is 6 to after 6 come at 12, then the action of the drug is totally lost. So we have to carefully distribute our medicine at the right interval. In case of an error in administering or distributing medicine happens, the authorized doctor must immediately be informed about the same. Any errors in a medicines, or if any side effect you see on a patient, then at the time we have to immediately inform the physician for or the side effect which you see on a patient. A record about a medicine should be entered in the register only. After administering the medicines, the register must contain the name of the medicine and the time of administration. Documentation, report, and recording is the main things after administering the medicines, because it contains all the details about the administered medications and detail of the patient also. These documents help that if you are doing first shift as staffing, then those who are coming after you, this record help to other person that is these medicines you provide the patient and other medicine you give at the time of interval. Through the record, they know very well. Next, legal and ethical aspects. Ethical and legal aspects of the medicine. The right to prescribe medicine is limited only within the doctor authorized by Indian Medical Association. Doctor who is authorized by the Indian Medical Association, that doctor is able to prescribe the medicine. While a nurse can administer any medicine prescribed by the doctor who prescribed it is responsible for its all side effect. If a nurse is administered any medicines which prescribed by the doctor, that doctor is completely responsible for the side effect of the medicine. All the possible side effect of the medicine should be explained to the patient is being to administer. If you know that the side effect of the drug is this, sometimes we are administered to antibiotic to our patient, then he or she feel nausea and vomiting. This is side effect is commonly you have to explain the patient that is side effect or show on you. So calm down, don't worry, it's going down after some time, and feel comfort. For this concert, he or she feeling the comfort that okay, it's happening for 5 minutes, 10 minutes. After that, I feel relaxed. Then the patient has a right to reject any treatment that he is not interested. Patient is not interested, then he or she has a right to refuse their treatment. Certain medicines such as morphine should be prescribed only by authorized doctor with respective license to do so. Those have a license or authorized doctor, they are able to prescribe the morphine, because morphine is a highly abused drug. It is used in India or in international level also. So authorized doctor are able to prescribe the morphine. One question I ask here to you all, that if as a staff we have to administer the morphine in 1 ml and the vial is 2 ml, then how can, if we have to administer only 1 ml, then 1 ml of morphine we take, another 1 ml what we do? Yes, we have to discard in front of authorized doctor or in a front of in charge, because it was reused as a abused purpose, because as previously I discussed that it is a highly abused drug. The medicine that passed expiry must be destroyed during the disposal. Expiry date we have to check before administering the drug. If the drug is expiry date crossed, then we have to immediately dispose it, dispose it. If the medicine that is being administered is under clinical trial, then an authorization letter is signed. Approval by the patient must be collected in advance prior. Any medicine you are going to trial on a patient, then before that medicine on trial you have to take one letter from the patient with signature of the patient, that I am going to try this medicine on you, so so and so you have to give this letter for your consent. Without your consent I am not going to start a trial medicine on you. So the document record on the details of the medicine administered to must be provided the patient with a copy retained at the clinic for the minimum 3 years. Those documents we have to prepare at the minimum 3 years, we have to keep in your clinic or hospitals. Morphine stock keeping. Morphine stock keeping. Morphine should be kept in a stock only by those medical institutions recognized and approved by the by the Drug Controller General of India. Drug Controller General of India, those hospital or clinic are approved by this. They can have a authorized to keep the morphine. Otherwise, small medical store, small pathology, they are not able to keep the morphine. The regulatory body mandate to have a doctor's separate location to store morphine to get an authorization. Once approved, morphine should be stored only from the authorized dealer. And the regulatory body has a mandate that authorized doctor have to prescribe the medicine morphine, and the dealer from which we have to get the morphine, that dealer is also authorized. A morphine stock register should be maintained that mandatory record the quantity of morphine sourced, the amount of morphine administered to a patient, and the detail of the doctor who prescribed it. All the detail related to morphine, that the doctor who has prescribed that medicine and what is the quantity of the medicine we are storing and how much we are spending, all these things we have to keep in a record. Maintaining stocks and records for essential narcotic drug in any institution. The consignment of ends. Here ends denote the essential narcotic drug in a cupboard, board or locker safely under the supervision of the doctor in charge of the recognized medical institution. The consignment, yani the stock of the essential narcotic drug should be keep under the recognized medical institute and under the supervision of the in charges. Record of the consignment note is maintained for 2 years in mandatory, and record we have to keep for 2 years. It's a mandatory. The name and address of each patient for whom essential narcotic drugs was prescribed are entered in the register along with the quantity, which we have to make the record. For this record purpose we have to know the name of the patient, know the which drug we are prescribing, and these all the records we have to keep in your hospital along with the quantity of the distribution of the morphine, all these things. For minimum 2 or 3 years we have to keep this record. At the end of the day, the total quantity of end distributed the day should be subtracted from the initial quantity with which the register was started. Means you start your shift at the 8 a.m. Then it is whole procedure is go down at the 8 p.m. Whole day how much distribute you morphine and how much stock is there. It means you have 100 doses of morphine, but in a whole day you are distributed 50 doses. So at the last of the day we have to subtract 50 from 100, then we know that 50 morphine is in our stock.
Once verified, the doctor in charge is sign below the last entry of the day of the register. All the register when you completely done, then you have to once verified and take a signature of the authorized doctor. All records are kept for 2 years from the date of the last entry. It means if your register is completely filled, then entry of the last you have to keep that register for minimum 2 years. Although support staff may manage the day-to-day entries, the medical officer in charge has the primary responsibility of the staff. It means supportive staff. Firstly, you do your duty, and other staff is coming. They have to also to maintain the stock of the morphine. Record of the day-to-day account of every transaction in is maintained properly. Day-to-day record we have to maintain. By this, we have easily know what how much stock we have available in our store room. Patient complaints, medication, medicine and complaints. Uh, See, for example, if we are taking a patient, TB patient, our doctor prescribed dot therapy for 6 months, but the patient symptom is going down and he or she stop their medicine within 2 months. After this, he or she come back to the doctor and say, my symptoms is again overcome. At that time, doctor prescribe high doses of medicine. That is the medicine compliance treatment of disease will effective only if the patient the medicine routinely and timely. If they follow the routine and time of the medicine, a proper interval of medicine, then its effect is completely come out. Making the patient fully aware the importance of adhering to prescribed medicine is an essential part of the treatment. Means ki we have to convince the patient that take your medicine on time, proper time duration, proper routinely we have to follow, and what is the importance of the medicine you have to take that you if you take that medicine on time, then your prolonged duration of care is go down and you have to treat within of 10 days, 15 days or 1 month. You have to properly treat. Why do patients not take medicines regularly? As you all, we are not interested to take a medicine regularly just because lack of awareness about the action of medicine or inability to understand the information and instruction given by the physician or pharmacist. Sometimes physician and pharmacist the language which we are not understand or which the patient or not understand, at that time patient have a confusion, so they are not want to take the medicines. Taste like the taste of medicine, no one like the taste of medicine, because that's why we are not taking our medicine. Fear of addiction to the medicine. Some patient think that if we are taking regular medicine, then we are addicted of the medicine. Problem associated with side effect, having to take multiple medicine at the same time. Same times we are taking so much medicine, and then we are avoiding that we are not taking medicine. Having to take medicine too frequently, prolonged treatment, the duration of waiting in a hospital, cost of medicine. Yeah, really, it's a very big issue that medicines cost is very high. That's why poor patients are not able to afford it. That's why they are not take medicines regularly. Medications adherence. How to convince the patient to adhere medicine. Discuss the need and importance of each medicines to your patient. You have to discuss the needs of the medicine and what is the importance of the medicine. Discuss when to take medicine before or after food, the correct dosage. Discuss the way each medication must be taken, tablet, capsule that should not be broken. Firstly, we have to discuss the needs and importance of your medicines, that patients have to, we have to say to your patient that if we take the medicine, you reduce your pain or you have to relieve out all these things, then we have to say to the patient that what time you have to do, before meal, after meal, what is the doses of the medicines and what is the correct form of medicine, which medicine you are going to administer, that is capsule form or any syrup form. So then at the time we have to explain to the patient. Discuss the way suppository are to be inserted into the rectum. When you are going to administer suppository, at that time you have to explain to your patient that you are going to insert the suppository to his or her rectum. Discuss how medicines are to be kept under the tongue, because some patients are not know how to
how to take a drug under the tongue. At the time when he or she unable to take the drug under the tongue, then you have to demonstrate them. Firstly, you demonstrate on yourself, then you have to say to your patient by showing he or she know how to take the drug under the tongue. Discuss the side effect, if any, of medicine. Discuss how to keep the medicine safely. If your patient is discharged from the hospital, then you have to say to your patient that how to keep your medicine safely. How to ensure the patient take his medicines. Visit the patient at his home and inquire about detail of medicine with the patient or the caregiver. Query for detail about the timing and quantity of each medicine being taken. If the patient is discharged from the hospital, then you have to visit the home of the patient and ask to the patient and his caregiver that the patient are taking medicine regularly or not, properly or not, and take, ask question to the patient that detail about the timing of the medicine, what, how much quantity you are taking medicines. Compare the packaging and the drug chart. You have a drug chart, through the we have to compare the medicines of the patient. Find out when and what quantity of medicines were bought and how much was remaining. At what time he purchased from the medical store, and now how much quantity they have remaining. We have to compare through the drug chart. Find out the problem associated with consuming medicines. Some of them have so much problem regarding the consuming medicine, because someone have unable to take a tablet through the oral form. Then we have to give in juice or in milk to dissolve it and give to take. Common mistakes regarding medicine. Mixing up of medicines packets after they are picked for consuming. Some patients are illiterate. They are not able to understand. They are not able to read and write or learn. Then they mix all the drugs, and by color of the medicine they decide to take. So mixing up and repeatedly taking one particular medicine instead of different medicine. If uh, two medicines have a same color, like yellow and yellow, then patient think that the same I take two different medicine, but he or she mixing up all these medicine and take one medicine repeatedly. Mixing up medicines of similar shape and color. More than one person helping with administering medicine, leading to an overdose of medicine. If two staffs are working together and they are not convey message to each another at the time, one staff administering the medication at 9 a.m. and second staff also going and administer the patient at 9:30, then it leads to overdoses of the medications. So we for removing this error, we have to convey this message to our staff that we are administering the medicine on 9 a.m. So you not go and administer again. More mixing up of medicine with different potencies. All medicines have a different potencies. So the patient mixing all the drugs, and the drug potency is different. Before conclusion, I am going to discuss scenario that if we are admitting a patient with a femur fracture, then femur fracture, doctor prescribe 3 days for morphine, but after 3 days patient have a craving that he want morphine for pain relief. He or she create drama also. At that time, as a nurse, how we deal with your patient? Okay, at that time, for temporarily dealing with the situation, we are taking dispo and filling with distilled water or normal saline, and inserted into the patient IV. Then we say that we are giving you painkiller. At that time, patient by mentally status is say that he or she get the painkiller, and she or he going reduce their situations. Conclusion, the role of palliative care at the end of life is to relieve the suffering of patients and their families by the comprehensive assessment and the treatment of physical, psychosocial, and spiritual symptoms patients experiencing. Standard practice must be followed while handling the drug, and cross-verify matching before administering medicines. While handling or administering the drug to the patient, follow the ethical and legal aspects. While you are handling the medicines, we have to follow the legal and ethical aspects of the medicine. So, so today I am discuss about the drug in a palliative care. Introduction of the drug in a palliative care. 10 most commonly classes of drug which we used in a palliative care center worldwide. Drug and their action. Evidence-based practice study. Storage of medicine. Safety measures while handling the medicine. Ethical and legal aspects of medicine. Morphine stock keeping and maintaining stocks and record for essential narcotic drug and in any institute, medicine and compliance. Why do patients not take medicines regularly? How to convince the patient to adhere to medicines? Thanks to all.
Thank you, Ms. Shivani, for your enlightening presentation. It's time for refreshment. We are going to take 20 minutes tea break and our next session will start after 20 minutes. Thank you, everyone. Welcome to one and all in our afternoon session. So now let's move to our final speaker, Ms. Supriya, will delve the topic of service delivery framework.
Morning, one and all present here. Today, I, Supriya, am very pleased to stand in front of you, share my topic. Before sharing my topic, I would like to tell you that I have taken my seminar content on three aspects. That is theoretical aspects and evidence based, and the third is that my primary rudimentary. So, before giving an introduction about my topic, I would like to tell you a very short story. So this short story you have to correlate it with the palliative care. It is not actually about, it is not medically related. So the story says that there, you all know about River Ganga, right? Okay, so there was a saint. He went to River Ganga. Actually, what we used to do, we used to take bath in that holy water. It has been said that if we will take bath, we will wash out all our sins. So that saint went to River Ganga. He said that the people are coming, people are washing off their sins in you. So where are those sins are going? Okay. So River Ganga said that you go and ask to God. The saint went to God. He arises the same question that where are all those sins are going? So the God says that you go to Ganga. You ask that question again. So saint came back. Saint asked Ganga where are all those sins are going? So River Ganga said that people are coming, people are washing off their sins. Then again, I'm getting my water is getting evaporated. It is again coming as a rain. So, relating with it with a medical term, the care that we are providing to the patient, if that care will not be appropriate, it will not give a good impact. Just like the sins that we are washing off in that holy water, that sins are coming again to us as a rain, right? So, in like that, if the care which has been given to the patient, if that framework will not be in an appropriate manner, if that framework will not be there, the care that we will give to the patient, it will not be effective and it will not be appropriate. So yes, my topic is service delivery framework. Okay, from last sessions, we are hearing this word palliative care, right? So you might be having somewhat appropriate knowledge of palliative care. Palliative care puts or it approaches the quality life care to the patient as well as their families. Okay, and these care has been given in the life-threatening illness. So palliative care basically revolves around only basically three things. That is the holistic care, interdisciplinary team approaches, good communication, and maximum quality of life to the patient. So these are the things in which palliative care revolves. So if the care that has been given by the service care providers, that care should not be delivered at the proper level, should not be delivered in a proper framework, it will not give a good impact to the patient. So there should be a proper framework for giving the palliative care. Okay, moving to objectives. So the general objective will be the learners will procure knowledge about the service delivery framework in palliative care, and they will intensify the positive attitude about the content in practice of their infirmary. Talking about the specific objective, to introduce the at the end of the session, the students will or the learners will be able to introduce the topic, compute the key components, cite the principles, relate the implementations that has been taken in the service delivery framework, and then the students will also able to comply the challenges and limitations of the topic. Then to justify the care of different levels, different care has been given by the different service providers. So the learners will also be able to justify the care that has been given at the different levels. Then to prescribe the future services and delivery framework. What are all the changes that will be made in future service delivery framework, or what are all the changes that has been already taken, so that also the learners will be able to understand. Okay, so in this content, I'm basically including the introduction, components, principles of service delivery framework, then implementations that should be taken in service delivery framework, challenges and limitations, and care at different levels, the services delivery framework. Okay, moving to introduction. I've already told you that palliative care is basically it is a holistic care that has been given to the patient in such life-threatening conditions. Okay, so the palliative care is directly associated with the life-threatening conditions, and if those care should not be given at proper level, should not be given at proper in a proper manner, then there will not be a good impact on the patient. So for that, a model should be there, a framework should be there. So that is service delivery framework. The delivery framework is a model of care for individuals with life limiting illness who are living at home or in community and their families or caregivers. So delivery framework is a model. Whether you are in home, whether you are in a home setting or you are in a community setting, you will get the appropriate level of care with the help of this service delivery framework. Then it is designed to enable care to be delivered according to the quality standard for palliative care. Service delivery framework told us the standards, what are all the standards that are needed to be taken at the time of giving care to the patient. As I have already told you in starting that in palliative care, you have to give the maximum quality of life to the patient. You have to give the maximum quality of care. So whether doesn't matter the person is in home setting or he is in a community setting, you have to provide that care to the patient according to the standards. The goal of delivery framework is for palliative care needs of patient, families, and caregivers to be met in timely and effectively. Again, with the help of service delivery framework, we can be able to give the treatment effectively and timely. Obviously, if you will not give the care timely, you won't be able to treat the patient, and the patient might be get some serious complications. Okay. Okay, moving forward, I guess you have much aware about the content that is service delivery. Now we will move towards the key components of service delivery frame. So for that, few points are there. Uh, the care should be patient-centered care. Okay. So the care that you are providing, it should be patient-centered. Means the patient's preferences you have to keep in mind when you are caring for the patient. Focus on the patient. The care should be tailored according to the patient needs. You have to modify your cares, you have to modify your services that you are going to give to the patient. It should be flexible, it should be modifiable according to the needs of the patient. And then respect for patient autonomy, you are familiar, you have to give independency, you have to give freedom to the patient so that he can choose, can take decisions for himself. And then involvement of family and caregivers. In while you are treating for the patient, it is very necessary to involve all the family members and caregivers in that particular. Then it should be there should be comprehensive assessment. Comprehensive assessment means wholesome assessment. You have to assess the patient completely. And then there should be regular reassessment. Regular reassessment, why it should be there? Because if suppose if there are any changes coming in the patient's symptoms, so that you can reassess the patient and you can modify your services according to that. Okay, then next is care planning. What are all the what are all the cares you are planning for the patient? That should be individualized care plans. Okay, individuality is there. Each patient are having different problems. So the care that you are planning for the patient, that should be individualized. You have to assess each and every symptom of the patient, then you have to plan your care according to that particular symptom. Then coordination of care, interdisciplinary team, communication and collaboration. In coordination of care, the care that has been given to the patient, it should be given via interdisciplinary team approaches, and that should be there should be a communication between all the healthcare members. There should be proper communication between the families and caregivers. Next, ongoing evaluation and revision. Okay, so why evaluation is necessary? Because if you will evaluate your care, you will be able to know what are all the pros and cons you have, what are all the pros and cons of your care. Okay, so you have, for example, patient was suffering from fever. You have given him the care, you have implemented some of the points. Okay, that I will give cold sponging to the patient, I will give comfortable position to the patient, I will provide a calm environment to the patient. In that you have implemented all these things. Now you will evaluate the condition of the patient. In evaluation, now you will see how much the patient has been recovered. If patient is recovered, that's okay, your implementations are good. But if the patient has not recovered, it means that you have to modify your care plan, you have to modify your care planning. Okay, clear? Next, quality improvement. Quality improvement should be there. Again, as I have already told you, you have to evaluate. After evaluating, if you see that your plannings are not appropriate, your plannings are not up to the standards, you have to modify them, you have to improve the quality of your care plans. Okay, moving forward, principles of service delivery framework. There are some principles on which the service delivery framework acts. Okay, first is principles of care. Respect the dignity and autonomy, holistic care, family-centered care, and cultural sensitivity. As I've already told you that you have to respect the patient's dignity. Okay, even though if the patient is going to die, you have to give a dignified death to the patient. It is not like that patient is, suppose patient is terminally ill, you are not giving appropriate care to the patient. So at that time, you have to respect for the dignity of the patient. You have to give that much freedom the patient so that patient can take decisions for himself or for herself. Then holistic care should be there. Wholesome care you have to provide to the patient. Family-centered care should be there. You have to involve family members also, and you have to involve caregivers also. Sometimes the family members are only the caregivers. Okay, so in that conditions, you have to involve family members, and not only to the patient. A palliative care means giving uh, giving treatment to the patient as well as their families. So it should be a family-centered care. And then cultural sense, you have to respect all the cultures, about all the cultures of the patient. Then the care should be patient-centered care. It should. So next principle, patient-centered principles that should be focused on the patient needs. It The care should be revolved, or the care should be tailored on the unique needs and standards of the patient. And then value their self-respect. If in most of the hospitals we have seen, especially in government hospitals, if we the nurses or the some healthcare workers, they are not talking appropriately with the patient. So at that time you have to think about the self respect of the patient. You have to call them with the humble voice, or you have to call them by their name. So that are all these things we have to take care if we are giving a care to the patient. And then prioritize the preference. What are all the preferences of the patient? We have to prioritize according to their. The next principle, holistic care principles. In that, integration of care is there. Integration of care means when there are two, three cares summed up together that we use to give to the patient. For example, like we are giving medical care, nursing care, and then any psychological support together. So that is known as the integration of care. Then continuity of care, even though the patient has discharged from your hospital, you have to ask the patient for regular follow-ups so that the care should be continued. And then comprehensive care, again a holistic care you have to provide to the patient. Then continuous quality improvement should be there. After evaluating your care that you have been given to the patient, you can evaluate about the quality of care, and then according to that you can improve your qualities. Then dignified death, I have already discussed. If the patient wants to die, you have to, have you heard about the mercy killing? So mercy killing, basically we it is with the will of the patient. When the patient is not able to live more than that, the mercy killing is used to give to the patient. That is also known as euthanasia. Okay, next is passive centered, family centered principles. Family centered principle, family involvement should be there because they are also the primary caregivers. Families are always the primary caregivers, we all know. So you have to involve families, you have to give emotional support to families. Then respect for the family values. Next is cultural sensitivity principle. If we are treating the patient, it is very necessary to keep in mind that the culture of patient is very important. You have to respect their cultures. I will give you example for that. In some hospitals, if the lady is married, she is wearing mangal suit. So while performing the surgery, some in some hospitals they don't remove, because we all know that we have to remove all the instruments while performing any surgery. But we don't remove Mangal Sutra. Instead of that, we used to apply micropore over that so that it will be fully covered. But we don't remove that. So by practicing these kind of things, we can preserve the culture of patient. And then quality and safety principles. In that quality care, you can give a maximum quality of care to the patient, and it should be based on the safety principles. Okay, next we will implementation of service delivery framework. What are all the needed implementation that need to be there in service delivery framework? First is planning and implementation. In planning and implementation, it is very important to gather a uh, good team. Establishing a planning team, for example, you have to recruit that particular staff for treating the patient, that who can provide that quality of care to the patient when they are dealing with that life threatening condition. Then conduct a needs assessment and develop a vision and mission statement. So while planning and implementation, you have to keep all the following points in your mind. Then service design. In design, define service scope and boundaries. If you are in any firm, or in if any medical firm, if they are giving any care, for before giving that care, they have to develop this. They have to define the services scope that they can provide to the patient, and along with that, they have to set up boundaries and limitations. Then develop services pathway. Service pathway means from the admission to referral or to the discharge, there should be a proper outline of the steps. If the patient is coming for the care, if the appropriate articles are not available there, if the appropriate advancement technologies are not are not there, then the patient is referred for further for more approaches. Then after that, if he or she is getting treated, he is discharged. So that journey from admission to from admission via referral to discharge, there should be a proper outline for all these steps. Then service implementations. Establish a service delivery team. You have to make up a service delivery team, those who can provide the service, those who can provide the care to the patients. Develop policies and procedures. What are all the procedures that we are going to give to the patient, that we are going to perform with the patient at the time of their illness? That procedures should be based on the limit, or based on the standards and policies. Then provide training and education. For provide training and education, we can focus on IEC, that is information education communication, by giving training by putting an effective focus on IEC, we can train the healthcare workers so that they can perform better. Next is service monitoring and evaluation. Service monitoring in evaluation, we have to put some established performance indicators. So established performance indicators are the parameters by which we can see whether the care that we are giving, it is up to the standard or not. Then collect data and monitor performances. What are all the care you have given to the patient? After that, you have to collect data, and then you have to monitor where the care that you are giving to the patient, it is up to the mark or not. Then evaluate and improve services. After collecting data, after establishing performance indicator, now you will be able to evaluate how is your performance. You have set the parameters, after that you have given the care. Now you have to compare whether the care that has been given, it is matching the standard of that parameters or not. With that you will be able to evaluate your services. Next, sustainability and quality improvement. Establish a quality improvement program. You can, for that, you can do some FDP in the healthcare sites. They develop a sustainability, foster partnership and collaborations. You can collaborate with some other healthcare organizations, with some other healthcare workers, and you can give a quality care to the patient. Okay, so these were all the implementations. Now moving forward, we will see what are all the limitations and challenges that the service delivery framework is facing. Okay, so first is organizational challenges. In organizational challenges, we face the most common thing, that is the lack of resources. In lack of resources, what can all be there, like lack of staffing. In community areas, the healthcare organizations are there, but there are not that much appropriate staff. So that because of that, some people do not get proper treatment, and the treatment also not started in time. So the lacking of staffing and also resource allocation. The lack of resource allocation is also there, which through which, because of this lacking, the patient do not get care at time. Then inadequate training. If the service care provider members are not getting proper training, it directly puts the impact when they are giving care to the patient. You are not properly trained, then how you will be able to give care to the patient? That care will not be appropriate. You will give care, but that care not will appropriate, and that care will not match the standards of the needs. Then inefficient referral processes. In some hospitals, still in community areas, the referral system is not working that much appropriately. Patient is, or we can say the referral system is somewhat delayed. Patient is ill, he need to be referred as soon as possible, but due to some, we can say, if there is lack of transport system is there, or the management of that particular healthcare organization is not appropriate. So because of that, some referral inconveniences are coming. So with that, the patient is getting delayed. The care that has been given at that time, it is getting delayed. So these are all the organizational challenges that has been faced by the service delivery work. Moving to clinical challenges, what are all the clinical challenges are there? Complex patient needs. Sometimes patient needs are very complex. In that condition, we don't know what are all the needs we have to prioritize. Then symptom management, when the staff are not that much trained, when there are not that much appropriate resources, at that time symptoms management also fail. Then psychological and spiritual distress. Uh, Suppose a nurse has given the appropriate care to the patient, but the patient has affected emotionally also. For that emotional affect, you have to give some psychological supports. But sometimes after giving care, they left. So these are all the clinical challenges that needs to be improved in the while giving care. Next, systemic challenges. In challenges, fragmented care. Fragmented care means when the care has been given at in few settings. Okay, it is not, the care is not giving at one time. For example, some care I've given now, but the another care should be given at different settings. So because of the changes of settings in giving care, the care might get delayed. So that's why fragmented care also has been a limitation for service delivery framework. Next, lack of standardization. If the staff will not be that much up to that will not if the staff will not be that much updated, so they are not that much knowing about the procedures or their principles, they won't be able to do the procedures properly. So that may lack the standardizations of the procedures. Then insufficient data and metrics. If the data collection has not been properly, if the history collections have not been properly, then there will be difficulty in giving the care to the patient. Coming to social, cultural and social challenges, there are some cultural barriers. in every, I'm not saying that in all organizations, uh, we have to respect, we have to give respect to the culture of patient, but everywhere it is not happening. So in cultural barriers also there, and then social determinants of health. We are talking about the social determinants of health. These are the housing, education, and poverty. So sometimes they also put an impact on service delivery. Then stigma and misconceptions. Talking about the stigma and misconceptions, there are so many misconceptions regarding palliative care. People think that it is a, they directly correlate palliative care with the end life care. But it is not so. If we are giving care to the cancer patient, suppose the cancer patient has been treated, now he is living happily at the home. We have given palliative care, but the patient is still alive. So we cannot directly say that palliative care is also known as end life care. It is somewhat associated with the end life care, but so this is the misconception that has been going in the patient's mind. They directly correlate if it is palliative care, it means it will leads to death only. It is not like that. And then technological challenges, limited access to the technology, especially in community area and in urban area, rural areas, the proper technologies are not present, advancement technologies are not there. With that, there is the diagnosis get delayed. Then data security and privacy. In data security and privacy, the persons are not able, we have to keep it, we have to keep the data confidential, but sometimes it is not, sometimes the data is not secured with the healthcare workers. So this is also a limitation. And then technological literacy. Technological literacy, the person are not able to operate the technologies. You have been provided the financial help, you have brought all the technologies, but until unless you won't be able to operate all the technologies, you won't be able to provide that advancement care. Okay, moving forward, we see the services or cares delivered at different levels. Now at different levels, what are the services and care that has been given to the patient, and by whom those services have been given, that we will see. So first is at community level we will see, then sub health centers and health and wellness centers, then primary health centers, health and wellness centers level, and then at secondary tertiary care facility centers. Okay, next we will see care at community. So in care at community level, the uh, the care that has been, or the functions that has been taken by the ASHA, that is identify patient in need and document palliative care services. You have to identify the patient, what are all their needs, what are all their problems. You have to identify, and that you have to, after identifying, you have to document whether the patient is in need of palliative care or not. Then identify community volunteers for palliative care. You have to identify whether you have that appropriate team, or you have that appropriate volunteers to give the palliative care. Then facilitate referral of the patients. You have to take care, if you are referring the patient, you have that much, the referral system should be very advanced and it should be quick. As soon as the patient is in need of referral, you have to do it immediately. Then the functions that has been taken by ASHA and multi-purpose workers, that is create awareness regarding palliative care. You have to create awareness, for that you can conduct some programs in the community. And then home care visits. With the home care visits, they can collect they can collect the data, they can get to know what are all the conditions that are in the families, and if there is any family members who are in need of palliative care, then they can give the palliative care to the following candidate. Then equip caregivers in simple nursing tasking, management of symptoms, and notify and refer those needing more care. Next, you have to manage for the symptoms. Uh, you should have knowing those appropriate procedures based on the policy, so that you can manage the symptoms appropriately, timely. And then if the symptoms you are not able to manage, then you have to notify it to your higher authorities, and then you have to refer the patient as soon as possible to the secondary and tertiary facilities. Then by multi-purpose workers, their function is to screen individuals along with the CHOs. They have to screen individuals when they came for the diagnosis. They have to do the diagnosis. They have to do the diagnostic evaluations, and then detailed assessment and nursing care. Assessment should be in detail, what history collection should be there, and then further diagnosis and evaluations that are needed, it should be there. And nursing care, appropriate nursing care should be given to the patient. And then maintain home care kit. While going for the home visits, they have the home care kit that they are having, they have to maintain that particular kit. Okay, next we will see what are all the care that has been given at sub-health centers and health and wellness centers. So we will see this, at this level the services has been given in three particular aspects, that is clinical function, public health function, and managerial functions. In clinical functions, the detailed assessment and home care is given to the patient, and then refer patient when need. If the home care is not particular for the, if the home care is not appropriate for the patient, they came for the they came for that uh, sub health centers. And if the patient is not able to be cured there, the patient should be referred as soon as possible. Then providing basic nursing cares. Public health functions, creating patient support groups. There should be a patient support group who can work for their betterment. And then conduct IEC, SBCC activities. You can go for the uh, education, information, education, communication activities, which will enhance the training, which will help aid in training of the healthcare providers. Then you can recruit community volunteers. These community volunteers will assist the patients. They will collect the data who are all in need of care. Then avail benefits for the patient and families. If the patient is coming for the treatment, you have to avail all the particular benefits, and you have to give those benefits to the patient as well as their family members also. Next, managerial function. In managerial function, supervise the sub-health centers, health and wellness centers team in identifying and line listing of the patient. If the patient is coming to sub-health centers, what you have to do, you have to identify the patient, and you have to enlist the patient, those who are in need, those who want the care, you have to enlist those patients. And then maintain records, those who are coming for the care, those who are referring, those who are getting discharged, you have to maintain all the records for the care. And maintain a list of palliative care hospitals and physicians. Next, you have to, in case if there is a referral, if you will have the list of all the secondary or tertiary facilities, you will be able to refer the patient as soon as possible. Okay, so here is a model that I'm going to explain. So the example which has given in this model is of advanced cancer. Okay, so instance if the patient is having cancer, there might be the admissions might be in four ways. Okay, so when the patient will come for the, you can see four admissions. Okay, it will be continued till the care, until unless the patient is not getting treated or until unless the patient is not dying. So when first admission care, the patient will come for the acute care. It will consult with the team, and then inpatient piece, that is palliative care unit. The patient will go for the palliative care unit. For the second admission, the patient will be either the, if patient is somewhat admitted, and then patient will be sent for the outpatient department. And in second admission, the patient is coming for the follow up, or it may be stand alone or embedded. In third admission, the patient will be at community based care or hospice care or for facilities. Means if the care is not appropriate for the patient, they will be referred for the further care. And these admissions will be continued till the patient is not either the patient is not cured, or the patient is uh, if the patient is not be able to cure, if the patient is going to die, these admissions, these follow-ups will be continued till then. Next, care at PHC and HWC level. So, in primary health centers, patient treatment under medical officers, and providing palliative care services at least once in a week. The care that has been given to the patient, they have to come at least for follow-up at least in a week. And then prescribe appropriate drugs, maintain separate case sheet. The drugs that has been needed for the patient, you have to provide those, you have to prescribe those drugs, and then there should be separate case sheets for the individualized patient. Provision of home care and end of life care services, those who need it. Necessary sensitization sessions should be carried out under medical officer. If the patient is having any serious illness, in that condition the patient might get fear of that particular disease, or patient might get panic. So for that there should be proper counseling session. Then ensuring referral services for secondary level of palliative care. Next, the care that has been given at secondary and tertiary care facilities. So the at secondary and tertiary care facilities, the service is given by basically CHC or MOIC, that is medical officer in charge. Provision of dedicated palliative care outpatient services at least once in a week for walk-in patients. Those who are coming for follow-ups, they have to come at least once in a while. At least 5 beds to be earmarked for palliative care patient. In at the secondary and tertiary centers, there should be at least 5 marked bed should be there compulsorily for the patients. Ensuring continuum of care at the hospital and provision of follow-up from the OPD. Monitoring and supervision of activities of PHCs and UPHCs. Provision of OPD consultations. Involvement of trained medical social workers, counselor or psychologist. So along with the medical services, you have to also aid in counselors and psychologists so that they can deal the patient emotionally. Ensuring inpatient treatment services including psychosocial and spiritual interventions, recreation and facility. Okay, here is one more model that shows the referral pathway of patients palliative care. So the patient, when the patient coming for the hospital, home-based care through health and wellness centers has been given to the patient. If that home-based care are not appropriate for the patient, they might have taken to the hospitals. In hospitals, they provide the care. If that care is not appropriate, they may be sent for the referral. But this care should be continuously going. Should be go with the patient. Um, Moving forward, there is a resource from Indian Journal. A study is there. The study related to knowledge about end of life care of terminally ill geriatric care patient services in northern India was conducted by Vivek Gupta, Sandeep Kumar, and et al. This is a cross-sectional qualitative study of focused on providers and recipient of palliative care. They have used various tools like questionnaire and interview method with sample of 500 doctors by using AQ, that is Palliative Care Knowledge Questionnaire. And the result shows 14 doctors, that is 28%, couldn't able to enumerate the technical elements of palliative service, whereas 4% of the doctors utilized palliative care service, but none had the training, and 68% doctors is unaware of palliative care services. This reveals that most of the health workers are unaware of or neglecting the framework of palliative services. This research leads to various discussion and research. So according to the study, the doctors were failed to give the care to the patient because they were not aware or they were not acknowledged by the service delivery framework and its functioning. Okay, moving forward, we will see the future services delivery framework. What are all the future implementations can be there in service delivery framework? That is integrated care models. There should be interdisciplinary teamwork that should work together to provide a holistic care or comprehensive care. There should be a collaboration between the healthcare providers, social services, and community organizations. Palliative care and euthanasia integration. Palliative care service will be integrated with the euthanasia assessment and support. So in India, we got the permission for passive euthanasia in 2011. India legalized passive euthanasia in 2011. The Supreme Court recognized that the person right to life includes the dignity of dying. If the person is having the right of life, he also include the dignity of dying. So with that, the India legalized passive euthanasia. Then personalized care planning, patient-centered care plans tailored to individual needs and preferences. According to the needs and preferences of the patient, we have to give care to the patient. Involvement of family members and caregivers in care planning. Then there should be some modifications in workforce development also. There should be increased focus on workforce development and training in palliative care. And interdisciplinary education and program must run for the continuous education of the healthcare service providers. Focus on quality of life, emphasizing on improving quality of life rather than just managing symptoms. Not only managing symptoms, you have to give the maximum quality of life to the patient. Then holistic approach to care, including spiritual, emotionally, and socially support. Okay, scenario under plot. I will tell you about a woman. So she is 46-year-old. Her name is Mrs. Geeta. So at the age of 46, so she developed some lumps in her breast. So she was very shy to tell about all these symptoms to the family members. So she went nearby center to see what are all the why these lumps are getting in her breast. So just like we are in our Sanjay Gandhi Hospital now, we have been also inaugurated the cancer ward. So with that, like that only in community center that lady went. She undergone through some mammography, some initial assessments. After the initial assessments, the that lady has undergone the treatment, some radical mastectomy as prescribed by the doctor, as suggested by the doctor. So what is the key point in this scenario? That the you will see the framework, like if that center will not be there, the women won't be able to go to the oncology center for the diagnosis. And when she has undergone the diagnosis, then she went for the further treatment. So like that, in a proper framework, she has undergone by the she has undergone by the treatment, by the care, and after that she has cured, because of the early assessment, early treatment, the women cured. So this is a key point of this. I'm concluding my topic. In light of this information, we have seen the service delivery framework in palliative care provides a structured approach to delivering high quality, patient centered care to individuals with serious illness. The framework emphasizes the importance of comprehensive assessment, care planning, and coordination of care, as well as the need for ongoing evaluation of care plans. Despite of all the challenges and limitations, the service delivery framework offers a valuable structure for delivering palliative care services that tailored the unique needs of patients. And now the service delivery framework is focused on the preferences and needs of the patient. Summary. So at the end, we have discussed about, I would like to summarize my topic. We have discussed about the introduction, and then we went for the principles of service delivery framework. We have seen the limitations and challenges of service delivery framework. And after that, we have seen the future services that we can involve in service delivery framework. We have also seen the referral pathway of service delivery. So yeah, I would like to end.
Thank you, Ms. Supriya, for your edifying presentation. Now it's time for lunch break. So we will be back with our session of certificate distribution and feedback session. Thank you, everyone.
Yes, sir. What do you
Thank you to all speakers for sharing their knowledge with us today. We hope that this seminar has provided you with a deeper understanding of palliative care and its importance and improving patient outcomes. We would also like to thank our faculty members, guests, and fellow students for their participation and support. Your presence has made this seminar a success. Attention, students, as we conclude today's seminar on palliative care, we would like to inform you that a post-test will be administered to assess your understanding of the topics covered. The link has been already shared on your groups. Your participation is mandatory and the results will be used to evaluate the effectiveness of the seminar. Kindly attend all questions and submit your response.
Now, we will move towards the feedback session. We want to touch base regarding our seminar on palliative care. We would love to hear your thoughts and feedback on this seminar. So, now I will request to our Vice Principal ma'am to come on the stage and give feedback about this collegiate seminar. Please come, ma'am.
Good afternoon to one and all. So in this occasion, I want to give a feedback session for our MSc nursing students who has been presented as an speakers, and it has been a good motivation for other members also who has been presenting as an other MSc nursing student as a BSc nursing. You are the forecomers. So for us, so this session, I don't want to give an more negatives because so palliative care is not like a canal. It is like ocean. So palliative care, it won't end with because it is going to deal with the emotions and our feelings. So here I would like to thank all each and every speakers. They have been taken their effort. So if you are taking on each speaker, so from the speaker of Miss Divya, communication skills on for palliative care. She has been represented her particular communication skills towards her life experience as well as and her experience day to day life what she has been understood and she has been spoken in her angle as especially evidence based also one or two she has been explained which has been linked. So this is the positive comment for her and the negatives I will be saying all together later. So if you are coming to Miss Arshita, she also given an excellent all the various aspects of pain types of pain scales which is related with palliative care. She has been discussed in very well, and as well as she has also given and with the foremost latest review of literature she has been just she has been taken and she has given a more explanation towards that. And if you are seeing Miss Priyanka, she has been explained about a pain management. So she has been explained about WHO ladder pattern of analgesia, how to be introduced, and in which angle we have to focus on the particular care in pharmacological as well as non-pharmacological management of pain. So if you are seeing a pain, it is not a somatic pain. Palliative care pain is not a somatic pain. So it is going to deal with beyond the somatic pain, like psychologically or socially, every aspects as a family also going to disturb. So she has been touched with each and every angle. And Miss Shubham, she has been dealt with ethics. So what to be as a people we have to be as a nurses, as a professionals. how we have to be beneficence for others, how we can able to avoid harm. So those kind of view she has been focused very nicely. Again, if you're coming to the vulnerable population in how we have to focus for as like marginalized group or minority group, or it may be a religious based, how we have to give a taking a vulnerable group as a child or as a pediatric care, how we can take care as like in a different angle she has been proposed her content. And if you're seeing Archana, management of wound, ostomies and emergencies, she has been widely she has been focused from the chronic illness. She has been picked up some of the examples and she has been kept her effort in as much as she can. And speaker Miss Divya, again end of life care, really it was a wonderful content because organizing the particular end of life care content is literally difficult. As I said, it is an ocean. It has to be it will be started from the acute, chronic, terminal, then end of life care. It won't be stopped with the end of life care. It will be move on to the bereavement process also. So she has been covered in all the angles and with the supportive scenarios and the evidence based also. And Ms. Shivani Shukla also, she is the seventh speaker and she was excellently, she has been presented how as we people, everyone we know how to administer this drug, but how to store. Sometimes mistake can happen in storage. Sometimes mistake can happen like medicine error, which will be starts from that particular storage and how we are taking and prescribing or administering that particular. See, for example, in India only we are not prescribing drugs, but in advanced or developed countries, as a nurse practitioners, clinical nurse managers will be there. So just they will by the phone call only they will say, or as a nurse, it is a protocol, standard protocols will be there. As a nurse clinical manager or nurse practitioners only, they will be prescribing what is the dosage of this particular client, palliative care, or if it is the patient is going to be end of life care. So what is the particular opioids can be given? It is a protocol already standardly they have been organized and kept up. So as a nurse practitioner, we should have to know about it. She has been described that particular part very nicely. And speaker Ms. Supriya Chobe, and she also explained. So as I always say, community to be focused. So why means the particular end of life care will be end with the community only, not with the hospital. Only few members they will be who is having a money, they will be end their life in the hospital. But community only most of, if you are thinking rural population, there are 70 percentage, 2/3 of rural population are there in India. We are not in developed country. So such a cases, she has been very nicely explained how the framework should be input and how we have to work throughput. She has been explained with the example how the rainwater comes to the earth, again how it is going back, how the sins coming again. Like that she has been explained very nicely with the same framework only as it is, how the throughput we are putting, then only the outcome will be positive. Otherwise it won't be, it will be goes like towards the negative feedback. So really I was from my bottom of heart I'll be encouraging my students of MSc. So such a wonderful seminar. They have been accepted our from the principal and vice principal immediately saying. So I was not thinking it like this. It has been kept up, and some negatives also is there. So this is not a dot. It will be infinitive. So we should have to go beyond this. So this is a one upliftment. It can be given by our management or as a managerial level, as a professors or principal or vice principal, we can give a stage. So this stage which will be uplift you in future also. So the negatives, what they didn't discuss. So that point of view, and yesterday as an audience also you have been asked the question. Again, some more debate has come between the faculty and me. So why the spiritual alone you are concentrating? I'll be end with that today. So let me go on to that beyond this feedback session. So difference between palliative care and hospice care. This has been a latest review which has been conducted by Journal of Family Medicine and Primary Care 2022. They have been conducted. So they have been scrutinized 90 articles. In that 90 articles, 12 only they selected, which is according to the criteria which has been communication between them, and how they are giving a care between by the professional nurses, advanced care practitioners. Like that, they have been analyzed and they have been taken care, taking a 8 qualitative study, and the 4 are mixed methodology. So like that, if they have been taken and they have been given this some differences, only few differences, which is I am focusing India's related alone. So it has been an foreign focused. Actually, developed countries, they are doing this. So even India also, we are doing like that one. But India, if while you are comparing, it is a developing country, as I said, rural population. If you are thinking community health center may nurse practitioner is there is a nurse practitioner, there is an advanced care planner. No. So we are having a multiple work towards the registered nurses. As the registered nurses only, we are working in each angle. We are the hospice care specialist. We are the advanced care planner while we are becoming a senior. So such a time we have to think integratively. So then only we can able to get the well-being or quality of life of the patient. We can improve. So let me see this. What is the difference between palliative and hospice? So if you are seeing time and onset of care, so palliative care, which begins with the diagnosis of chronic illness, even acute also we can take, but it will be moves towards the chronic. Bone fracture of femur, if you are taking, they have been given in a morning example, fracture of femur. But at the same time, if you are not taking care of them, it will lead to bed sore. It will be leads to physical immobility. So such a cases, they will be leading into the chronic illness. So these people, if within 6 months or within the particular time period, they couldn't able to cure, or it is not at all healing, it is going to further more complication, one to another system which is affecting. So such a cases, they are going to get within 6 months, they are going to die. So such a cases, they will be moving this palliative care into the hospice care. Again, this will be begins with the time when the patient having a 6 months or less than that. Okay, at the same time, some of the time limit we are saying it's a God gift also will be there. Okay, it may be extended 7 months, 8 months, but the patient will be in the end of life care with the hospice care. And the treatment aspects, if you are seeing, primarily it will be based on the actual particular illness where they have been sought and where they are going to be there. So this will be primarily dealt by the doctors, and they will be adding the other supportive management. So emotional will be there, mental will be there, spiritual will be there, social and other symptomatic supports will be there. So if you are comparing this palliative to hospice, it is restricted. That means the particular drug which is not at all responding, particular pain management is not at all responding. So such a cases we will be, that is, they are going to be end with their life. So in those cases, along with this is additional, this is along with that, this particular emotional, spiritual, social, mental support will be given. So additional is different, along with is different. So this is the one different. And if you are taking a place also will be different, because where we are going to sort it. So it may be starts from the hospital, or where as a outpatient clinics or specialized palliative care centers or clinics and the homes. It will be end with the homes also. And if you are taking a hospice care, mostly it will be, usually it is a hospice means in a olden days we will be, as morning Miss Divya said, host, hotel, like that we will call. That means some house where we can stay as like. So like that they have been preferred, as patient will be prefers where they want to be. I want to be in with my daughter's house. I want to be with, because it's my end of life. The patient will be prefer the hospice. But palliative cannot be preferred, because they will be in something they doesn't know what it is. So it will be starts with the hospital, it will be starts mostly with the home, and it will be retired home or specialized hospice care centers, or it may be rarely hospital who is having a more money, so they will be staying up to end of life. And prognosis, short term, long term. So at the same time, cure also will be there. If it is not curing, they are going to end the particular disease is progressive, means they will be moving on to the hospice care. It ends only with the death, end of life, hospice care. And if you are seeing type of care, types of care if you are seeing, it will be start with the addresses the patient mental, physical, social, spiritual well-being, everything. But it is going to focus on diagnosis to treatment. But this will be not going to diagnose. We are going to extend the quality of life with the words or with the emotional support. So always we need a family members to support them. Without family members, we could not do this. So it will be continued in some of the countries, developed countries, brave men's support also they will give until 13 months. They have been lost their loved ones. See, for example, in India, tsunami has come. So immediately, so many children has been lost their life. So how long as a government could able to support it? Only few. Okay, but if you are thinking in a particular developed country, they are having economically high. So they have been 13 months they are supporting. So without their insurance, they will be having an insurance, they will get separately also. So like that they are getting. So how far? Because we are economically now only we are growing. So as we are the family members, we have to support our palliative or if the patient is in our hospice care. Again, provider, if it is you are seeing multidisciplinary team members who is highly qualified. So if pain nowadays pain pain nurse manager level is there or pain management colleague doctors are there separately. So they will be the deciding authority. So multidisciplinary team which has been focused on primarily based on doctors, specialists, or specialized nurses, or counselors and social workers. But if you are seeing a hospice care, it will be moving on to the family caregivers or hospice nurse, home care nurse, or social workers, chaplains who is going to deal with the spiritual activities. And occasionally only a doctor will be involved. Maximum, they won't be there. So these are all the some differences. So now I think so somewhat I cleared. So if you want more points are there, you can have it. I will end why I said spiritual. I'll say for that also answer for to my faculty. Okay, because it's life experience while I'm sharing, you will be knowing. And WHO's pain relief pattern, this ladder only we are following. As a professional nurses, we should have to aware of this. How to use in a chronic illness or terminally ill patient. So always we should have to start with the step 1, then we have to move on to the step 2 and step 3. See, if the illness is progressive, they could not respond if you are starting with the step 3. So that particular resistant as well as it could not be. So that means their quality of life will be decreasing. So always as a nurses, they will be, see why I am focusing on this. As a doctors, they will be giving this drug SOS order or PRN order. This two order, it will be in our hand only. PRN is nothing but whenever the patient requests. SOS, if necessary, as we are thinking, we have to give it to the patient. So in these two aspects only we will be dealing. So if patient will ask, you, if you are dealing with a cancer patient, you are being given at a time of 8 a.m. paracetamol. Again 9:30 they will be requesting. If you are checking a temperature, only half an hour it will be remains normal. After 45 minutes or 1 hour later, again it will peak of 101 and 102 above. So definitely we have to give again one more time. Like that it will be having a query. Some ethical dilemmas also is there. So such aspects we have to go ahead with the non-pharmacological management, and the communication is very, very important. How we have to deal to reduce that. So so in this part as a nurses we should have to concentrate. Always we should have to go from the step 1 to step 3. So then it will be easy to reach our particular quality of life, or we can give a ease of death to the client. Next, if you are seeing communication, so one is pain, whether it is somatic pain, we will be following. Next, communication is not for pain, it is for psychological and our emotional or our mental support. So if you are seeing this in advanced developed countries, they are having a two path. So they are having a direct pathway and adaptive pathway. So adaptive pathway will be carried out by our registered nurses. And this direct pathway, which will be advanced practice nurses like clinician, nurse practitioners, advanced nurse practitioners, like that specialty wise they are nowadays it has been extending. Even in our India, it is extending, but it will bloom slowly. It has been already raised. So if you are thinking, what is this advanced nurse practitioner and the registered nurses they will do? So both are there. One, they have to initiate the care. The another one, engage the care. So initiator is advanced practice nurses. So they will be dealing or they will be prescribing this. And the registered nurses, they will be engaging with the care. So two members together, they have to go ahead with the patient and family experience. How we have to deal? Already this has been discussed. Rapport by emotion, how we have to be developed there, how we have to get their emotional to be decreased, and as well as trust and confidence. We have to make them to be trust first, because we are the third person. They won't believe you immediately. So as a patient. So then if you are thinking understanding of the patient and family members also, then involvement of the patient and family, where they have to involve. So their patient ka values, patient ka what are all the care, everywhere we have to involve the patient and family. So this will be long in the cycle. It won't be a full stop always. It will be in the cycle. As the nurses, we should have to have a good communication attitude, how we have to perceive their emotions. And as a nurses, we should have to have a knowledge. Knowledge means integrated thinking. So it is not a one small aspects, we should not, all the angle we should have to think. And communication skill. So without communication skill, we could not able to take over the goals. So together it is integrated. That means it's a cyclical process, up and down. Both way it has to be gathered the information, sharing the information, and you have to respond to the emotion of the patient and family, as well as fostering the relationship between the nurse and patient and family. The whoever is the nurse, senior, that means advanced nurse care practitioners, or it may be a registered nurses or case managerial level. So they will be focusing on goals of care. Each goals which has been started with the patients and family. Why means it is a end of life. So that time, or chronic illness. So each and every aspects we have to ask patient. And we have to, if patient could not be able to answer, we should have to go with the family members. So we have to go like that. Either goals and values we are identifying. Whether this patient is as compliance. Ms. Shivani said this word, compliance means agreeing. Whether the particular patient is agreeing for the treatment, that particular painkiller they want, why they don't want, why they are requiring that. So we should have to put that questions. As like patient prior experiences, whether they have been having a past experiences, they can share with us. Then they have to, whether prognosis is there. So I said it should be a less than, the patient is going to be within 6 months, they are going to come with the end of life care. So that time the prognosis not there. So what is the prognosis level, and what is the initiated, any changes are there, whether we are going, the patient is chronic to, they are moving on to the hospice care. So this which will be giving a better outcome. So input will be as with the nurses. Nurses are the main input here. There is no other persons are here. In this article, they're just focusing on nurses, because 24 into 7 we are going to work. So such a cases, input are the either registered nurses or the practitioners. The throughput completely, which is focusing on patient and family with the goals, what we are going to achieve. So it will be giving a best outcome for us. What are the best outcome? Our quality of life of the client has been increased, whether they have been decreased their particular emotions, they are very peace, they are very joyful, whether they are quiet or with emotionally and somatically, like that we can able to see that. And if you are seeing a wound care, it is not any type of wound, because the patient is going to lie down on the bed for a long time. It may be a ostomies, or it may be any bed sore wound, or which has been surgical wound, which has been created and they have been become a chronic illness. As the nurses, we should have to integrate it with the four things. First, timeline. So when the patient admitted, what is the future? This timeline we have to see. and how we have to deal with the wound. Everyone we know wound assessment, wound care, everyone we know. But this wound, what is that? When the patient comes 5 centimeter wound and the patient is going to the hospice care 10 centimeter wound. So what is the difference here? The quality of life is decreased. Automatically you know the answer. So the wound should be moving forward with the what we anticipated. What is your goal? What 5 centimeter wound is there? We have to reduce into 4 centimeter. So that anticipated decisions we have to have in our mind. As well as within the demands, always we should have to take a demands of the patient. So how I have to be? I'm going to give this wound care. This is your wound assessment. Like that, if you are thinking the current patient demands, we have to keep it. And it will be move on as well as every time we will be reassessing. What is the previous status? What is the current status? So that should be compared. So then priority towards the wound healing to be always our focus to improve our quality of life. So this also which has been taken as a secondary sources from the review of article. So this has been done, this study has been done among the nurses who has been worked with the palliative care 2022. It has a qualitative methodological study. This is also evidence based. And if you are seeing, this is the end. So as I said, physical, psychological, social well-being with spiritual well-being. So this I am not going to discuss. Why means already you people all know very well. So I will say my life experience. See, once one mother who's helpless with the husband and she is living with the 3 daughters. The daughter who's she also studied nursing and 4 years or 5 years she worked in a reputed hospital. But even though the mother is supporting for some negative things towards her family members, at the last stage, she's going to die within 3 months. She knows that. But at the last stage, she's suffering from breathlessness or something. One daughter is doing massaging, one daughter is holding her back because breathlessness, no. So our home and all, there is no backrest. We have to hold like that only. So upright position ka liye. So one member is calling, please give some injection to ease. So such a time we are neglecting or some negative emotions will be there. So we should have to, as a professional nurses, we should have to out of the negative emotions. If we are having in our heart, okay, that time giving an injection, you can give an injection. So at the same time, please put your some spiritual words towards them. As I said, the end of life, only hearing acuity only will be there. If you are touching also, they could not able to recognize you. While you are holding also, you could not recognize you. You are catching her hand. You are putting a bronchodilator to decrease the breathing difficulty. She doesn't know, but immediately she will die. We are crying or we are saying some other words. It will go to her particular mother's ear. You think about that mother. At last she died, but there is no hope. What is the word at last we said? Nothing. It's none other than my mother. At last, I didn't said any words to my mother. I'm putting in bronchodilator. My one daughter, my sister is holding a bag. One sister is massaging. She doesn't know anything. Now I am recognizing. Even I was having a 4 or 5 years experience. I have been. I don't know how I neglected. As like some negative feelings was there. I didn't spoke with my mother. Just I'm holding and I'm giving a bronchodilator. Now I am realizing why I did like that. Instead of bronchodilator, I can give some. Anyway, she's going to die. We know that. So after bronchodilator, within a second, she died. So like that, we handled even in my hand. See, several things I did. The last one word I couldn't put to in my mother's ear, ear to hear the good words. So as a people, this is my life experience I'm sharing with you. As you people, while you are caring for your patient, always say good words to them. Communicate. So why I'm saying good words means a flower acha hai or gulabi, you remember karo, guided imageries are there. Rather than those words, spiritual words you create. It will be keep on in their ear and it will goes to their brain. It will be in the heart. So once they are going, where they are going, God only knows whether where they are going to reach. We doesn't know anything. So please have a touch with your patience with the mind and the soul, not only physically. Don't treat it. So be always, we are always proud we are a nurse, because I'm just now I'm saying I am very eager to do my MBBS. I hate nursing that time, but I am proud because in my hand my mother has been died, no problem. But I know how to administer medication. I know how to give my pain medication. I learned, I have been preferred. So please, all the professional nurses, as a MSCs or BSCs or whoever the registered nurses you are working, please have compassionately and as well as spiritually, please guide them to reach the quality of life or well-being or end of life. It should be ease with the breath. So thank you one and all for giving this opportunity as an feedback session. I've been very much thankful to our management as administrators, managerial level, as well as our principal of IGSCon, and as students also, for everyone. Thank you one and all.
Thank you for your valuable words, ma'am. Dear participants, we are pleased to announce that the certificate of participation for the seminar on palliative care are ready now for distribution. Everyone, let's give a big round of applause for our participants. Uh, I would like to call respected principal sir to come on this stage and distribute the certificates. I would like to call Miss Divya for she presented topic communication skill for palliative care.
I would like I would like to call Miss Piyusha, ma'am. I would like to call Miss Harsita, ma'am. She presented topic assessment and management of pain.
Now I would like to call Miss Priyanka. She presented topic pain management for critically ill patients. Miss Shubham Maurya, please come on the stage and receive your topic, receive your certificate. Now I would like to call Miss Piyush for topic palliative care in vulnerable groups. Now I would like to call Miss Archana for presenting topic management of wound ostomies and emergencies in palliative. I would like to call Miss Divya again for end of life care. Miss Shivani for drugs in palliative care. Miss Supriya, she presented service delivery framework. I would like to call Rakesh Kumar Chaurasia for participating in for attending the seminar. He is a student of MSc Nursing first year, batch 2024 and 25. I would like to call BSc Nursing fourth semester representative students Miss Aarti and Miss Khushi to, to receive the certificates. Thank you so much, sir. Thank you, everybody. And let's again give a big round of applause for our speakers. And now I would like to call Miss Piyush for vote of thanks. Good evening, respected principal, sir, respected chief guest, esteemed guest of honor, vice principal ma'am, distinguished speakers, faculty members, and my dear colleagues and students. It is my pleasure to stand here before you as we conclude this enriching 2 days intra-college seminar on palliative care. First and foremost, I would like to express my heartfelt gratitude to our chief guest, Dr. Mariamma C. John, Principal of Sultanpur Institute of Nursing and Paramedical Sciences, for taking the time to grace us with presence and for sharing valuable insights. Your words have truly inspired us all. We are deeply honored by participations and we thank you for being with us today. We are greatly to our thanks to our administration or an administrator, retired Wing Commander Mr. Manoj Muthu sir and CEO Mrs. Sarmila Roy Chaudhary ma'am for your valuable guidance even in their absence. A special thanks to our guest of honor, Principal Dr. U.S. Siddiqui sir, Vice Principal Mr. S.D. Singh sir, including Admin Manager Mr. Suresh Kumar Singh Rajput sir, COO of Sanjay Gandhi Hospital, Mr. Avdhesh Kumar Sharma sir, OT Manager Mr. Sarvesh sir, Sanjay Gandhi Hospital, Nursing Superintendent Mrs. Krishna Mukherjee ma'am, your constant support and encouragement have made this event possible. I take this golden opportunity to express my heartfelt thanks to our principal sir and vice principal ma'am, our seniors and junior faculties of nursing and non-nursing staffs also. Our heartfelt thanks to all the eminent speakers who have shared their expertise with us. For first day speakers, Ms. Divya, Ms. Harshita, Ms. Priyanka, Ms. Piyush, and Ms. Subham. For day two speakers, Ms. Archana, Ms. Divya, Ms. Shivani, and Ms. Supriya. Your lectures on crucial aspects of palliative care, such as pain management, communication skills, ethics, and end of life care, has significantly increased our knowledge and practice. A special thanks to our wonderful anchors, Ms. Supriya and Ms. Archana, Ms. Priyanka and Ms. Harshita for flawless guiding us through the session and ensuring that the seminar proceeded smoothly. I would also like to extend a sincere thanks to all the participants without whom the seminar would not have been complete. Your active participation and excitement to learn have contributed to the success of this event. A huge Thanks to all the organizers, the MSc Nursing batches 2022 to 2023, 2023 to 2024, and 2024 to 2025. Your hard work and dedications behind the scenes are truly commendable. This event is a testament to your commitments and advising nursing, education, and healthcare profession. Finally, I would like to express my gratitude to Indira Gandhi School and College of Nursing and the Nursing Education Studies Center for providing such a wonderful platform for us to come together and learn. As we conclude this seminar, let us take forward to the knowledge, compassion, and empathy we have gained and apply it in our professional lives, helping those who need our care and support the most. I extend my huge thanks to Ms. Aisha ma'am, Mr. Abhijit sir, Mr. Deepak sir, and all over the team of digital media who help us to go live. And special thanks to our channel rgcsk.edu. Thank you once again to everyone for making this seminar memorable and enriching experience. Have a wonderful evening and we look forward to seeing you at future educational events. Thank you.